A very warm good morning to all the delegates who are present here. We'll start the program in another 5 minutes. More participants are getting in, so we'll start the program in another 5 minutes. Thank you. Department of Community Medicine, Bhaarath Medical College and Hospital extends a warm welcome to our respected Dean, Vice Principal Sir, to the guests of honor today, the respected speakers, and dear delegates to the virtual CME on systematic review. This is Dr. Sharath. We are actually so happy and excited to see the response that we have got for this program. Nearly more than 350 participants all over India have registered for this CME. And that says how important and interesting this topic is for the researchers, but still it is less explored. So looking forward for this CME and hope you all benefited by this program. And with the same excitement, I would like to invite our respected Vice Principal Sir to address the occasion with his few lines.
Am I audible? Am I seen? Hello? Am I audible?
You're audible, sir, but video is not on. You're audible, sir.
Now, video is there, sir? Hello?
No, sir. Sir?
Hello? Shall I speak, sir?
Yes, sir, you're audible, sir. Yes, sir.
Good morning to all. It's indeed a great pleasure for the Bhaarath Medical College and constituent unit of Bihar, Bhaarath Institute of Higher Education and Medical Research, to organize this fantastic CME program by the Department of Community Medicine. We was really thankful to our respected chairman, Sir Jagat Rachakan, and our president, Dr. Sandeep Anand, who are so much benevolent to allow all those participation like this. And our Dean Edgonli is always with us to support us on this thing. Really, it is indeed our HOD, Dr. Levani, is a very dynamic person who is always, I know her, even her postgraduate days at Madras Medical College when I was dean there. And again, at the Satya Sai Medical College, she was the associate professor when I was dean. And she is very active on this thing. Very recently, only he has joined this college. Within the short period, she has done a lot of things. And one of that thing is this CME on this thing. Really, this topic is very, very important in the sense, unless you review the articles properly, you will not be able to proceed whether compile other things, whatever you want to do, presentation or thesis and all. So in that way, it is really important topic, and moreover, the MCA has also made review articles as acceptable to count for the promotion and all. So it is really important for all of us to learn how to review the articles properly and then submit this. We ourselves can produce a lot of papers on this. So such an important topic is being organized. I'm really thankful to the department. I wishing all the best. I'm happy to inaugurate this. Thank you.
Thank you, sir. So before moving on to the scientific session, there are a few points that has to be made. Any queries, please put in the chat box. The session for discussion will be open only at the end, and the participation certificate will be generated for those people who fill up the feedback form. So please, a feedback form will be given at the end of the session. So kindly fill that for your getting your participation certificate. So let's move on to the scientific session.
Good morning, everyone. Our first speaker will be Dr. Kalaivani A. Madam has done her post-graduation from Madras Medical College. She has completed her PGDFM from CMC Vellore. She is a FAMER Fellow. She has been a project coordinator of Unnat Bharat Abhiyan. She has around 84 publications and 11 copyrights to her credit. Madam has been resource person and organizing chairman for various workshops on research and copyrights and patent nationally and internationally. She has worked in various funded projects. Currently, she is with us as professor and head of Department of Community Medicine, Bhaarath Medical College and Hospital. Dr. Kalaivani ma'am will be speaking on overview of study designs and significance of systematic review. Over to you, ma'am.
Thank you, Dr. Vidya. Am I audible?
Yes, ma'am, you are audible. Just few minutes, like you will be able to share. 1 second. Yes, ma'am, you will be able to share your PPT now.
Is it visible now? My screen?
Yes, ma'am, it is visible.
Okay. Good morning, one and all. A special welcome to our speakers. My topic is on overview of study designs and significance of systematic review. These are all the things I'm going to talk in this session. There's a famous quote of Albert Einstein: if we knew what we were doing, it wouldn't be a research. The thing is, while proceeding for a research, we have to have clear-cut research question as well as clear-cut research methodology. That is, if we knew what we were doing it, that is, if we knew the results before our research process, that is not quite a research at all. But we have to have some clear idea about what we are going to do in research methodology. So as you all know, the research process will be having different steps, and we are going to deal about this research design and planning. And study design is nothing but a specific plan or a protocol for conducting the study, which allows the investigator to translate the conceptual hypothesis into an operational one. Why we need the study design? Because different studies will have different challenges and difficulties. The study design will have its own steps as well as inbuilt features like randomization, matching, and so on, that will take care of the difficulties and challenges of the research process. So it also make the research process as efficient as possible with producing maximum information with minimal expenditure on time, effort, as well as. So coming to classification of study design, before going to proper classification, I want you all to know about the different points to be considered for this classification. First of all, you have to classify whether you are going to extract data primary from the patient or participants, healthy participants, or secondary data from already published resources. And then the second point is whether it is observational or experimental, or whether it is a qualitative exploratory study or a quantitative study, or whether the study is having any comparison group or without comparison, and whether the study is testing the hypothesis or generating a hypothesis, or whether it is going to find any association between some variables. And it is also important to know the timing of conduction of study, whether it is a cross-sectional single time study, or you are going to do a follow-up, or you are going to do any retrospective study. So it depends upon the unit of population, whether it is individual or population, it will differs. And one more thing is, you have to know how many contacts do you have with the participants, whether single time as in cross-sectional, or 2 times or more time as in follow-up or cohort study, or before and after study, more common in medical educational research projects. And the final thing is whether it is involving human research or animal research. So these are all the points you have to look before deciding the study design. This is the evidence pyramid and study design. As I told before, depends upon the participants, like whether it is humans or animal, or observational or interventional, or primary research or secondary research. The study design will be differing. Initially, sometime back, this pyramid will be looking like the top of the pyramid is having meta-analysis, followed by systematic review, RCT, cohort, case control, case report, and case series. But by the evolution of publication itself included many sub thing called expert opinions, editorials, and then clinically appraised articles, and so many things. And one more important thing is, previously meta-analysis was given the top in the pyramid, but now meta-analysis and systematic reviews has been given equal place in the pyramid. As I said before, your question, you have to frame research question, and depends upon the question, you have to ask whether you are having interventional study or clinical trial, or just observation. In observational study, again, whether you are having any comparison group or without any comparison. If you are having a comparison group, again, it's divided into on the time of progression of the study, it's single study, for study, or prospective study. Study will be divided into case control, cohort, and in under the study, any comparison group, that is called as descriptive study designs. In that, you will have case report, case series, cross-sectional, and ecological. One more important things you have to know: cross study is become both study and analytical study. The such questions you are and the object formulated, and if you are going to find out the association between variables, it will be like the analytical cross-sectional study. Is simply just measuring the burden of disease prevalence or knowledge attitude KP study. It is just a descriptive cross-sectional study. That is an important point you have to know. So other study designs and all: nested case control study, descriptive cohort study. Descriptive cohort study means it will be having that the particular study design will having a follow-up component, but there is no control group in that study. So for a proper cohort study, you will be having a control group, so that the validity of the result will be even more good. But in descriptive cohort study, there is no control group, so it will be placed lower at the evidence pyramid. So this is the picture that shows the study designs in accordance with the increasing strength of epidemiological evidence. As you all know, RCT is the gold standard research to prove any causation. As you go down, that is cohort, next comes case control, cross-sectional, ecological, and descriptive study. That is in the lower bottom, you will have all the case report, case series. So that the strength of proving causation will be minimal in the lower end of the pyramid. As it goes up, the causation of proving the causality will be more. So while you're selecting the study design, you have to keep in mind the research question, as I told before. So if it is if your objective is the description of a study, you have to have either a case series or case report. If it is like, if you want to find prevalence of a disease, it is cross-sectional studies appropriate design. Then if you are going to find out any incidence of a disease or incidents or events, then cohort is an appropriate design. Cause or etiology, then cohort or case control study design. If you want to check the prognosis of a disease, obviously cohort study design. And if you want to test or compare newer interventional methods or treatment effect, then it is interventional study. Either it is RCT or quasi-experimental study design. That is, quasi-experimental study design will not have any one of the component of RCT. That is RCT. To call RCT, you have to have randomization and a control group. For summarizing literature, you have to, we are having the systematic review and meta-analysis. So depends upon the research question, it will vary. So, so as I said before, this expert opinion, editorial and all recently included. Previously, when research publication started, there were only original article, and then slowly systematic review and all included. Of late, this expert's opinion, editorial and all included. But when you are taking the type of evidence, it is it is having only least evidence for proving the causality. Similarly, as I said before, whatever the studies without any control, the level of evidence it is proving is very, very minimal. This is according to this Sackett article. So of late, you are having this critically appraised topic. This is nothing but a website or a journal where the experts will be reviewing one topic or a drug, and they will be reviewing recently published articles, and they will compile the results and will give the results, and this thing is peer reviewed. So that is the difference between critically appraised topics and systematic review. So ideas, editorials, and opinion, this is put forth only by experts in the field. It is normally by invitation only. As I told before, it is the least reliable source of evidence. This is one example of editorial. Under descriptive studies, you'll have case report, case series, descriptive epidemiological study. Case report is nothing but one case of unusual finding. Case series is a group of such report. The findings of multiple cases with unique features. A case report, rare cases, previously undescribed diseases, unexpected link between disease, unexpected new therapeutic effects can be reported in this case report. Even adverse events. This is one such case report, and neurosyphilis a case report. So case series, it's a group of cases with similar diagnosis. Maybe rare disorders can be having as case series. This can't prove causation, which whether some particular agent is causing some disease or not, because there is no comparison group. Even if it is a lowermost in the evidence pyramid, this case series also will be having some clear objective question, well-defined protocol, inclusion and exclusion criteria. See this in this example, they were having this objective methodology, everything put together. But the thing is here, you won't having any comparison group. So descriptive studies, you have to remember 3 P's. Person, place, period. This is the first step in the overall conduction of a study. Simplest form of a study. It is used to generate hypothesis, but not for testing hypothesis. and it will answer all the 4 W's, like who are all having the disease, what is the factor, when it was affected. For example, if it is a Nipah virus, so who are all got affected, where the Nipah virus got, and when it was when this disease got. For example, in Kerala, we got this Nipah virus. So it answers, if you want to do a study to find out the number of cases in that particular area, you have to do this initial study descriptive. So this is a study to stimulate the initiation of further study. So as I told before, this descriptive study, you will be having descriptive cross-sectional, analytical cross-sectional. So what is the difference between descriptive and analytical? Descriptive, you will have describe the magnitude. It will describe the magnitude of the problem. It may be disease, disability, or other nutritional events or conditions. It is used to generate hypothesis. Both are used to generate hypothesis. This analytical cross-sectional study, coming to analytical cross-sectional study, it will measure the exposure and disease simultaneously and used to examine the association between the factors or variables. But you can't tell which comes first, so you can't prove the causation. This is one such article on cross-sectional study. So depends upon the, as I told before, depends upon the reference timing. The study design is divided into cross-sectional, cohort, and case control. If it is a study conducted at one particular point of time, it is called as cross-sectional study. If you are doing some follow-up, then it is called as cohort. If you are collecting the history then retrospectively, then it is called as case control. First, analytical study, the direction is very important here. So in case control study, you will start with the cases, and then you will retrospectively collect the history and find out the possible factors that is initiating the process of the disease. So here, most commonly, this case control study is used for diseases with rare causes. Sorry, rare diseases. One such example is risk factors for deep vein thrombosis and pulmonary embolism. You can't do this as a population study or a cross-sectional study. So coming to cohort study, is otherwise called follow-up study. So you will start from the exposure and you will follow up and find out the disease or outcome. This is one such famous study, Framingham heart study. This is still going on. It started way before 1940s, and the cohort is in 3rd generation right now. The RCT, you have to, this is the gold standard study design. It has to have randomization and comparison groups. And you can have 2 groups or 3 groups, depends upon your research question and objective. This is one example for RCT. So coming to systematic review, the main topic of this webinar. So definition, systematic review is the process of systematically locating, appraising, and synthesizing evidence from scientific studies in order to obtain a reliable overview. That is very important. If you want to have a reliable result, you have to go for systematic review. As I told before, stressed in the earlier PPT slide, it is a source of secondary research. We are not doing or conducting studies from taking data from the participants or study sample directly. We are utilizing articles which are already published and grouping together using some transparent methodology and getting the result. So it is very reliable. So coming to history of systematic review, it is the first earliest systematic review was published way before in 1753 by James Lind, as you all know, for survey evidence. vitamin C as one of the causative agent for scurvy, but there was so much gap. It gained momentum during 1970s after this Cochrane introduced this Cochrane collaboration, Cochrane database. Is the earliest systematic review by James Lynn on scurvy. So evolution, it seems it is divided into foundation period, institutionalization period, diversification period. So in foundation period, because of this computerization of bibliographic indexes like Medler, Medline, and there was a more number of RCT coming out, and followed by which is institutional period where computer software has been introduced to facilitate reviews, and this Cochrane database, Campbell database and all evolutionized, and the very important thing is evidence-based medicine concept has been gaining momentum from this 1990s period. That's why they have given so much importance to systematic review and meta-analysis of late. The last thing is diversification period, that is 2001 till date. So new types of reviews, and under systematic review itself, there are so many types. Under reviews itself, there are so many types of reviews, and see, in 1980s only there were only 10 systematic review articles. Now means in mid 2015-14, it is increased from 10 to 28,000 systematic review numbers. It shows the importance the research scholars are giving to systematic review. So this is one article published from JAMA. This is assessment of publication trends of systematic review and RCT. It shows as you go from 1995 to 2020, the trend of RCT and systematic review meta-analysis is getting increased. And specialty wise, it shows that this hematology and oncology, this specialty is giving more number of systematic review compared to other specialties. Participants, can you have any guesses on which country is having publishing more number of systematic review? Any guesses? You can put it in the chat box. USA. Yeah, very good. That's the correct answer. Systematic review. So USA tops the world list in total number of systematic reviews. What was the answer? Any guesses in relation to systematic review? So I'll tell. So this is one slide from the same article, a review of recent trends between 1995 to 2017. You see the blue shades are the country with the highest number among the entire world. So yeah, China. For meta-analysis, it is China. That is quite interesting to know. This country is having a more number of meta-analysis and systematic review and other kind of article clinical trials. The USA is leading. And you see India. We are having this period between 1995 to 2017. It is 247 systematic review and 201 under meta-analysis. So guys over there, I want you all at least after this session, try one systematic review or a meta-analysis, depends upon your expertise, and publish it so that our numbers will also count. So systematic review, when we are talking about systematic review, we can't separate evidence-based medicine and systematic review. Evidence-based medicine requires the integration of the best research with our clinical expertise and our patient unique values and circumstances. When you combine this, you will have this evidence-based medicine, because if some other evidence in USA tells one findings, you can't extrapolate the same to our country, because our Indian population is having different ethnicity. So depends upon our clinical expertise, we have to adopt our own this thing, but we can't completely deny the results. So this is a repetition of the previous one of the slide. This is the evidence pyramid. Here you can see the top thing is systematic review and meta-analysis. These two are the source for clinical practice guideline. So this is chopped off. Final that triangle is chopped off from the remaining pyramid. So this is what I'm talking about. This critically appraised sources, up to date, Dynamed, clinical evidence. These are ACP Journal Club. These were the sources where you can find critically appraised articles where expert in that field will review articles in the peer-reviewed journals, and this particular findings will be again peer-reviewed and then displayed. That is the difference between these things. So recently I have seen this one, this is new proposed evidence pyramid. Here they chopped off the top systematic review and meta-analysis, and they were waving of lines between the different study design, telling that there is some of the features are getting mingled between the study, and the systematic review and meta-analysis considers a lens through which other type of study design were reviewed. So coming to why we are giving so much importance to systematic review, because it being a transparent method it is practicing, it will deliver a clear and comprehensive overview of available evidence on a given topic. It's not a broad topic, a specific topic. It will give an answer to the specific research question. Clinician relies on systematic review for informed decision making, and it will help to identify research gaps in our current understanding of a field. So if any one of the postgraduates want to do a new study, interested in doing a new study, they can search the systematic review and find the knowledge gap and put out your own research question that will answer the gap, fill the gap. And it will highlight methodological concerns in research studies that can be used to improve future work in the topic area. That's what I just now discussed. So it will identify questions for which the available evidence provide clear answer so far, and where and all we need further research. That is also the point we have to consider. So even the granting agencies like ICMR and the DBT may require a systematic review to ensure there is justification for further research or not. Clinicians read them to keep up to date with their field. Often used as a starting point. This is very important. The systematic review and meta-analysis is a starting point for developing clinical practice guidelines. We often see ICMR or ADA for guidelines. So they in turn depends upon not one article. They will see so many articles put together, that is systematic review and meta-analysis, to give such guidelines for recommendation. And clinical decision in medicine ideally depends upon this knowledge, available knowledge from systematic review and meta-analysis. So that's what I'm telling. Single clinical trial, even if it is a study which is having so many number of participants, you can't rely upon that. So some research has proven to be incorrect after multiple number of studies in the future. So we can't rely upon a single study. That's what I'm stressing on. And the truth needs to be understood by analyzing different sources critically and analyzed and objectively as possible to have a final reliable results. That is what we are getting from systematic reviews and meta-analysis. So this is the process of entire systematic review and meta-analysis. They will collect the results from multiple studies, and from that we are getting this evidence-based medicine. From that, guidelines, recommendation, and policy changes have been made. So, for example, insecticide-treated bed nets for children, it is not one-day policy. It depends upon multiple results of this systematic review, and depends upon the effectiveness. This has been proposed as a policy change. What's so special about a systematic review? Because systematic reviews are very transparent about how their conclusion are generated. You know the table where they have got that articles, how many numbers, what are all the inclusion criteria, exclusion criteria, everything are very transparent and explicit, and it produces comprehensive result on a specific question, not a broad question. A protocol is very clear. An indication for systematic review, it will uncover the international evidence, confirm and current practice, address any variation, it will identify new practices, identify and inform areas for future research, identify and investigate conflicting results, produce statements to guide decision making. So coming to different types of reviews, this is one slide where I want to stress there are more number of review types, mild differences in between, like critical reviews, systemized review, overviews, systematic reviews, qualitative review, umbrella review. Umbrella review is a review of reviews. Meta-analysis, literature review, state-of-art review, narrative review, mapping reviews, scoping reviews, rapid reviews, and mixed method reviews. Some quite differences are there. So I don't want to go in detail because time is very less, I suppose. So coming to magnitude of publication trends. So when you see a review, the major proportion is coming from narrative or traditional review. The systematic review is the next thing, and a smaller proportion is from meta-analysis. So meta-analysis is will take some more time than a systematic review to perform. That's why the proportion is very less, and it needs some expertise to do. So among the reviews, this is the order in providing in terms of speed of conduction of that study, and the bias, incidence of bias, and the comprehensiveness. As you see, the systematic review and meta-analysis have it takes more time to do. It is more explicit and transparent. It is having such a methodology to conduct, and it is having decreased risk of bias, and it will give more comprehensive, reliable results on the topic. So this is the level of confidence. The systematic review and meta-analysis is the top thing, and the narrative review in the lowest. Other types of reviews include effectiveness review, experiential reviews, prevalence incidence review, diagnostic test accuracy, prognostic, methodological, systematic review. Coming to advantages and disadvantages, is nothing but limitation of the study. Advantages, as I told before, transparency in the selection and interpretation of supporting evidence. Conclusion, that is providing a reliable result, which is more generalizable than single study. It's focused on narrow, clear-cut topic and question. Best patient management decisions and guidelines can be framed, and it is having very less bias, and it will draw reliable and accurate conclusion. It will also identify both best and bad practices. Disadvantages, limitations, you need some expertise to do. That's why we are having so many number of participants to make them aware of the different steps involved in the systematic review. It will take quite considerable time, and if you consider only one database, then the results will be not that much reliable. You have to pull all the database from different sources. Like when you are taking a systematic review, it is having exclusive database like Cochrane. You can also have Pubmed and other sources. Not only you should not rely only on Pubmed to retrieve the data. Search strategies were often not provided in detail. In some of the study, it is not, you should not generalize for all publications of SR. Many reviews did not provide adequate summaries, and the validated checklist were not followed universally. These are some of the limitations. Where it is used commonly in medicine, field of medicine for evidence-based, then later it is applied to management, public health, and medical education too. So these are some of the example of systematic review. This is a rapid review. It's a mixed method review that's combining both systematic review and other studies. This is narrative review. This is scoping review. Coming to meta-analysis, the difference between systematic review and the meta-analysis is you are combining the results of different studies with not the topics that have sufficient research evidence to allow for meta-analysis. But can have systematic review for those topics. Critical topic just now we discussed. This is one example. Some reviews are considered research, and it is a source for evidence-based medicine, and you will have a conclusive reliable for a topic and question. These are my references. Thank you. Any questions, put it in the chat box. We will answer it later.
Thank you, ma'am. That was a wonderful presentation. Our next speaker will be Dr. Ramya. Dr. Ramya has completed her post-graduation from Bangalore Medical College and Research Institute. She has completed her SRship in JIPMER. She worked as a consultant in India Epidemic Intelligence Services, ICMR. Now currently she is working in ICMR, NIE as Scientist B. She is working as Principal Investigator for Compliance Assessment for Cigarettes and Other Tobacco Products Act. She has been a mentor for many fellow scholars. She is working as a content developer for Scientific Writing Module and COVID-19 for online short course in ICMR. She has been working as a learning management system. She is working in various outbreak investigations, and she has written a book also, as she is a co-author for impact of COVID-19 on psychosocial status of general population. Dr. Ramya, we are very happy to have you with us. She'll be speaking on Introduction to Systematic Review.
You. Can I have my slides projected?
Yes, Dr. Ramya. Just give us a few minutes.
Sure. Thank you. So I welcome you all to the session on Introduction to Systematic Review. Next slide. Next. Okay. For the next half an hour, I'll be giving a background idea about systematic review, how to frame a research question, and what are the process involved in conducting a systematic review. So let's quickly jump into the basics of systematic review. So it is important to ask question in order to get an answer. The most important and the basic question that has to be asked now is, what is a systematic review? Next. A systematic review is an attempt to identify, appraise, and synthesize all the empirical evidence that meet pre-specified eligibility criteria to answer a specific research question. So say, for example, if somebody asks, is garlic a really good thing to take for a cold? It becomes a research question. So usually you have got an intervention. So in this case, it is garlic or some preventive strategy that for a condition. So what a systematic review is attempting to do is to find all the relevant studies that would address that question, and then we appraise them to see whether we think they are reliable or not, and then we summarize their results together. So we get a complete picture of the body of evidence on that particular question. So why is it called systematic? The systematic part is that we have to be systematic in your searching of literature. You have to be systematic in the methods that you use to evaluate. because anyone can write a review of literature. So I can randomly pick some top 10 trials on garlic that works on common cold, and I can just summarize them and come up with a solution. But a systematic review means you're looking for all the evidence that has been published on a particular intervention, and you're coming up with a solution. So after knowing what a systematic review is, the next question that comes to our mind is, why do we need a systematic review? Next slide. In order to bring out any decision, we need evidence. So we know that evidence on healthcare interventions come from clinical trials. But what if several trials have explored the same interventions and come to different conclusions? Obviously, we would need to somehow look at all these trials together, and that is exactly what is done in systematic review. So a systematic review helps in generating comprehensive evidence on a given topic. It can also aid in evidence-based decision-making as it uses robust method to reduce bias in the gathering, summarizing, interpreting of the research evidence. So in addition to this, a systematic review is preferred over a narrative review as a preliminary step in conducting an implementation research to identify the most effective intervention available for a particular condition. So at this stage, you might wonder, what is the difference between a systematic review and a narrative review? So let's look at the difference. Next slide. So a narrative review are generally created by experts to provide an overview of a broad summary of a particular topic. So they are like the subject matter experts in a particular field who give a broad idea of a very broad topic. So they are susceptible to bias, and the author may not clearly state the methodology used in the review process, and they might have selected the studies as they wish. So the main difference are, in a systematic review, there are more than 2 authors. So out of which one will be always a subject matter expert and one will be a methodological expert. Whereas in a narrative review, you have a subject expert, but we can't assure to have a methodological expert. So in case of a systematic review, you always register a study protocol, you have a very specific question with PICO format, and you have a comprehensive and repeatable search strategy, and you have inclusion and exclusion criteria that is specified prior to conducting a systematic review and are agreed upon by the methodological expert. Whereas in a narrative review, you don't have a protocol. Your research question is very broad, and you have no such strategies, and there is no specified criteria for selection. And a systematic review always go through a critical appraisal process, whereas a narrative review, it may vary or it might not happen also. Next. So what is the advantage of conducting a systematic review over a single study? You can always go for an RCT or any type of study design, but why do we need a systematic review? Because it saves the reader's time and it provides a very reliable evidence, and it also resolves inconsistencies, and it identifies gap, and it also establishes that the question has already been fully answered. So for example, if I have enough evidence on a particular topic, like for a drug is acting very well on a particular condition, I don't have to do the same research again and again. So in that case, the systematic review will tell us that we have enough evidence on this particular topic, and it is enough to conduct further research on this particular topic, so that the research can stop there and we can concentrate on something else in that particular field. Next. So a systematic review will have these are the basic characteristics of a systematic review. So a systematic review will have a clear defined objectives. It will have a predefined eligibility criteria stating the inclusion and exclusion criteria. So explicit reproducible methodology with details on the systematically searched literature. And after selecting, each study is validated, and finally the results are systematically synthesized and presented. These are the general characteristics of a systematic review. So whenever we talk about systematic review, the immediate question that always keeps popping in our mind is, why this is systematic review? Or when this is systematic review, what is meta-analysis? So let's look at what is a meta-analysis. Next slide. So meta-analysis is a method of combining the numerical data from several studies on the same topic to produce an overall statistic. The main benefit of doing a meta-analysis is that it can increase the precision of findings. The included studies may be if you are doing an individual study, a single study, it may be underpowered, which means that they haven't included enough participants to detect the effect of an intervention, or a difference between the study group, or there might be a difference between study group. So combining the results of the individual studies in a meta-analysis increases the statistical power and thus the precision of the findings. The results of meta-analysis are usually presented in form of graphs. They are called as forest plot. The interpretation of the forest plot will be explained in the upcoming presentations. So, how does it differ from a systematic review? How does a meta-analysis differ from a systematic review? So, systematic review involves only things like defining the question, searching the literature, assessing the quality of the included studies, whereas the meta-analysis is a method of contributing the numerical data from several studies on the same topic produce an overall statistic. Generally, a systematic review may include one or more meta-analysis, but they can also have no meta-analysis if statistical combination of the numerical data is not possible or appropriate. With this, we have a basic understanding on what is systematic review and why do we need a systematic review, what are the characteristics, and finally, what is a meta-analysis. Now, let's move on to the next section, that is review question. Next. The first element of the systematic review is framing a question itself. Next. So a well-defined review question is essential to a systematic review. So why is it so important? So it's important that you are clear about what your review will cover, as the question will define many of the subsequent steps of the review. So first is the question will determine your eligibility criteria. That is, which studies are included in the review and which are excluded. Second is the question will determine how you go about your search strategy and what kind of studies you will find. And if you are not clear enough about your question at this stage, you might miss papers that are really interest to you, or you will find a lot of papers that are not what you want. So third is the question will inform you which outcome do you want to measure. Are there specific issues you want to explore, and what information do you need to find in the included studies? And finally, the question will guide the interpretation of your findings. Have the studies and the results you have found answered the review question? Are there any gaps or indirect answers? Which are the most important findings to highlight in your conclusion and summaries? So we have understood how important it is to have a well-defined review question. The next is how to ask the right question. So now I will introduce you to the term called PICO. So what does PICO stand for? So PICO stands for the 4 critical components of an interventional review question. So P is participants or patients, I is interventions, C is comparison, and O is outcome. When planning your review, you will need to think about all 4 components and define each one. So participants are who you are interested in studying in your review. Intervention is what is the intervention or the group of intervention you want to test. Comparison is what will the interventions be compared to. Outcome is what outcome will tell you which intervention is the most effective. So kindly note this form holds good only for the interventional reviews. Not necessary that all the research question will have all these 4 components strictly. So when you doesn't have a comparator, or when you strictly doesn't have a say comparator, then you can leave that particular component and you can just move ahead. Next. So let's see one by one. So what are the basic types of review question? The first one is interventional review. So in interventional review, we compare 2 or more interventions on a range of different outcomes, or to compare a particular intervention with no outcome at all. So let's take an example to explain that. So here the research question is, what is the effectiveness, safety, and acceptability of surgery versus medical therapy for heavy menstrual bleeding? Next. Next. So in this, we can see that the patients are patients with heavy menstrual bleeding. And the intervention is surgery. And comparator is medical therapy. And the outcome is effectiveness, safety, and acceptability of the intervention. So this is how you form a PICO format for an interventional review. Next. So the next type of review is diagnostic test accuracy review. So in diagnostic test accuracy review, you assess how well a diagnostic test performs in detecting a particular disease. So the review question is likely to ask how well can a test diagnose and detect a disease by. So for example, do molecular tests detect infections better than the standard culture methods for detecting infections in newborn babies? So using the PICO format for an accuracy question is not straightforward. Unlike questions about interventions, the target condition in a test accuracy question is the condition we want the index test to detect. So here we prefer the alternative acronym PITR for test accuracy questions. What are these four letters represent? So first one is population, next is index test, target condition and reference test. So in this example, the population is newborn babies. The next is index test, that is molecular test, and the target condition, that is detection of infection. And next is the reference test that is used here, that is the standard culture method. So you need not always have a reference test. A review question can also very well address the accuracy of a single index test. In this case, you can omit the reference test. So the next is we are looking at the prognostic prognostic reviews. So prognostic reviews assess the probable course of a course or the further outcome for people with specific health problems. This includes identifying important prognostic factors that might influence the course of the disease. So here let's look at the example. So what is the predictive performance of the Framingham-Wilson model and the pooled cohort equation in male and female separately for predicting 10-year risk of cardiovascular disease in a general population? So here we prefer the alternative acronym PICOTS for prognostic review questions. So we have 6 letters which represents population, index model, comparator model, outcome, timing and setting. So let's look with an example. So in this example, the first one, P stands for the population is the general population divided by male and female. The next is index model, that is the pooled cohort equation. The next is comparator model, that is the Framingham-Wilson model. And the next is outcome, that is cardiovascular disease. And next is the time horizon, which is 10 years in this case. And the next is setting, which is nothing but the primary care and public health settings. Okay. So the next, what we are going to see, slide. So next is in this next type is methodological review. So in methodological review, we address questions about how research is conducted and reported, including systematic reviews and primary studies such as randomized control trials, or it can be anything. So for here, let's look at it with an example. What are the effects of using an active versus passive parental consent on participant recruitment and outcome in studies targeting children and young people? So how does it form a methodological review? Actually, we are looking at the methodological part, that is active versus passive parental consent, which is one of the process in your methodology. So in this example, the population is the children and the young people, whereas the intervention as such, it's not an intervention, but it's an active consent versus passive consent, which we are comparing. And the outcome which we are looking at here is participants recruitment and outcome rates and the impact of the consent as such. Next. So next let's move on to the process of conducting a systematic review. So let's be clear, these are not the steps of the systematic review. This is the process of systematic review. Next. So what is the process of systematic review? So we generally have two processes simultaneously. So one is conducting a systematic review, and the other side it will be the editorial process. The first step in conducting a systematic review is you define a research question. You define the question. And then you prepare a plan to how to conduct a review, and you write it down and you prepare a detailed protocol. And then you publish the protocol. Or at the max, you can register the protocol. It's not necessary that all the protocols has to be published, but registration of the protocol is must. and then you go on to conduct the review, and then you publish the review. Next is you update the review, and then you publish the updated review. These are the process of conducting a systematic review. So what is Prospero? So I've told you about registering the protocol. So Prospero is an international database of prospectively registering the systematic review. It provides a comprehensive list of systematic review registered at inception, that is before starting the study. So when you go to the Prospero database and if you have a research question, and if you go to the Prospero database and if you search for that particular research question, if someone has already registered that research question, it will show that. So you don't have to do it again when someone else is doing. So it avoids the duplication of systematic reviews. And it also reduces the opportunity for reducing the bias by enabling the comparison of the complete review with what we planned in the protocol. And the registration and process Prospero involves the submission and the publication of key information about the design and conduct of a systematic review. And it also provides a transparency in the review process and avoids the duplication. Next. So what is required for a Prospero registration? You need to have a complete protocol with you beforehand, before registering. And then the submission must be made before starting the data extraction. So if you mention as data extraction has already started during the Prospero registration, it will not get accepted. And submission must be always in English. Next. So there are some points like what do we need, who all do we need to be involved in a systematic review? So you need authors. So why do we need different authors, various authors? First is for cross-checking, double-checking the results. So there are some points in the review process where work should be double-checked, such as final decision about including the studies in the review, checking for errors in data collection and entry, and any subjective decisions, such as those about the risk of bias or your included studies. So we always need double checking, and we need different people's perspective, because multiple authors can provide different perspective in different area of expertise, which can improve the quality of your review. You may have authors from different disciplines or different geographical settings also. And next is you need experience, people who are experienced in conducting a systematic review, so that they provide methodological expert during your conducting. And you should also involve people who are consumers, that is various peoples who would like to read your systematic review after you complete it. So you can involve them, and you can take their perspective since the starting of the systematic review, so that you provide a detailed conclusion to them. So these people might be either policymakers, your healthcare professionals, your patients, or a methodological person. So you need to address all their perspectives as well. Next. So what are all the logistics that are required in your systematic review? First is time. So on an average, it takes minimum it takes 1 year to complete a systematic review. So if you take up a Cochrane review, it stated that it takes nearly 30 months to complete a Cochrane review. So you have to decide whether you have that much time with you to start a systematic review. Next is you need expertise and access to all the literatures. That is, you need access to the database like Embase, Pubmed. You should know how to access them. So that is required. Next is you need a team of authors. You need different people who is a subject matter expert, who is a methodological expert, who is ready to extract the data, synthesize the data, who knows how to analyze the data. So these kind of different categories of team is needed for a systematic review. And at the end, you need softwares, because generally we enter the data either in Excel or Stata or R. So all these softwares are needed, and we have also RevMan. So these kind of softwares are needed to carry out a systematic review. So there are some limitations for the systematic review also, because findings can rarely be considered final and conclusive, because there are many people, many researchers who keep updating the research on a day-to-day basis, and new evidence keep coming daily. So after conducting a systematic review, we can never tell that, okay, this is the final result. So we need to keep updating our review. And next is dependent on the availability of studies and the information. suppose if only the positive studies which has positive results get updated in the PubMed or your MBase, you will only include those studies in your review, and you will leave out the studies which are not getting published. So that is one of your limitation. So not always the systematic review can form into guidelines for treatment, because sometimes the guidelines after forming a systematic review, usually majority of the systematic review are formed as an international guidelines by WHO, but WHO's guidelines are at the international level. So when you are bringing them to the local setting, you always need to carry out a clinical trial in the particular local setting, say for an RCT. You have to carry it out before implementing the guidelines in your local setting. So that is one of the limitations. So yeah, I understand this is actually one of the contradicting factor, because systematic reviews are considered for guidelines, but it is only at the international level, not at the local setting, because some of the interventions which are applicable for America may not be applicable to India or Tamil Nadu per se. So you need to be very vigilant when you are implementing a guideline in a different setting. Okay? And more often, um, many clinical trials, they assess the benefits than the risks. So this is not per se the limitation. We can also assess the risk. So it is per se the idea of the team or the people who are conducting the systematic review. Next. So the take-home message from this session is systematic reviews are considered to provide the most reliable form of evidence for the effect of a medical intervention or markers. So, but how reliable are these information is subjected to question, because first thing is we have to look at the quality of the studies that are included in the systematic review, and per se next is we have to also look at the methodological quality that is being followed in our systematic. Okay, next. So thank you. So if you have any doubts, you can post in the chat. So we'll address your queries.
Thank you so much, ma'am, for opening many eyes on the systematic review. Dear delegates, if you have any questions, just put in the chat box. We'll address it at the end of the session because we are running short of time. So the next speaker is Dr. Mary Gilbert Mazela. He had completed his MBBS and MD Community Medicine from JIPMER, and Sir have completed his SRship from JIPMER, and he was a former consultant on basic course in biomedical research, ICMR and IE Chennai, and he is currently working as an assistant professor in Venkateshwara Medical College, Hospital and Research Center, Puducherry. Sir have won the Best Paper Award in the second JIPMER Research Day, and the Thesis of the Year by BNJ South Asia Award in the category of the postgraduate thesis. And Sir is currently principal investigator of 3 extramural and intramural funded projects. And he has been a resource person for more than 11 workshops, and he have 34 published articles and many more on his way. So Sir will be speaking on the topic, the steps in systematic review. Over to you, sir.
Thank you, Dr. Sharath. Can you please enable screen sharing for me?
Yes, sir. Yes, sir. We are doing it.
Dr. Gilbert, I think you can share now.
Yes, ma'am. My screen visible?
Yes, sir, it's visible.
Okay. Am I audible enough?
Yes, sir.
Yeah, thank you so much. Good morning to one and all. In this session, I am going to walk you through the steps in conducting a systematic review. So we have already heard enough about systematic review, what it is and why it is being done, and what are the advantages and the limitations. So we will only focus on the steps in about how to go about and do a systematic review. So these are broadly the 7 steps of performing a systematic review. So we begin with a review question, which we saw in the previous session, how to frame different kind of review questions. We will also touch upon few aspects of it before going on to the other steps, like framing eligibility criteria, which studies to include and which studies to exclude from our review. Followed by how to perform a literature search, how to get the different articles which are pertinent to answer our research question, and how to select those studies which are directly related to our research question, how to do the data extraction from these studies, and how to report those results in the manuscript. So I would be covering the initial steps of the systematic review, and in the next session you will be looking at how to assess the quality of the individual studies using different tools, and how to interpret the data and results presentation in the subsequent presentation by Dr. Yuvraj. So we have already had a session on the review question, so I will just quickly go through this. So how to choose a research topic? We usually conduct a systematic review only when there is uncertainty around a particular problem, when there is unclear evidence about a particular research question. So the evidence is still not very far or against a particular intervention. We are not still satisfied about the measure of association, the strength of association between an exposure and an outcome. So in these situations, we go about and look at all the evidence which is available around the topic, and then we try to make some conclusions out of it with whatever literature is available. And most importantly, even before beginning the literature systematic review, so please go back and see if that study has already been published or a similar review has already been done in the Pubmed. So most often we start this process, and then halfway through we find out that a similar article has been recently published, and then we try to leave it there. That should not happen. We have seen different, there are several frameworks for developing a research question, like in the previous speaker told. We follow PICO with some modification, D and S as an addition, but most often all these frameworks generally follow the same kind of patterns, like the population, intervention, exposure, or the comparison group outcome. So we will, for this presentation, we'll stick on to the PICO with T and S supplements. So this also has already been covered. What are the different components of the research question we will be talking about, because this is most important part, because the subsequent steps, whether you're fixing your eligibility criteria or your inclusion exclusion criteria, or going about and doing a screening for the studies, all these things will depend upon your PICO. What is your population? What is your intervention? And what is the thing which you are going to compare the intervention against? And what are the outcomes which you are looking at? So this is very important for all steps of systematic review. And one more thing I want to add on now is the basic steps of performing a systematic review and meta-analysis are one and the same. Starting from your review question, choosing the eligibility criteria, data collection, literature search, data extraction, till that step, systematic review and meta-analysis are almost the same. The difference comes only when there is when you go on to the analysis part, wherein there is the systematic review and meta-analysis diverge at that step. Then the initial steps are going to be one and the same for both systematic review and the meta-analysis. So these are some kind of researchable questions. I think we have already covered enough of this, but just to take you on board, I'm just trying to say that the research question which you are trying to ask could be any of these things, whether you want to look at the incidence or prevalence of a disease. like what is the incidence of low birth weight or what is the prevalence of diabetes in this population. That could be the kind of question you are answering. Or you want to know the effectiveness of a intervention, either a drug or a vaccine or a behavioral intervention. So what is it doing to the outcomes? So that could be a kind of research question. Or it could be a screening test, whether screening for a particular cancer can help in reducing mortality in the long run. That could be the kind of questions you are asking. Or diagnostic accuracy, or to understand the prognosis or the survival in the patients following with a particular health condition. So that could be one of the questions. Or conventionally, we'll be looking at the cause and the effect, whether a particular exposure is causing a particular outcome. So that also could be answered. So all these kind of questions can be answered using a systematic review and a meta-analysis. So now, when we are looking at the steps, we want to know what kind of study designs to include in the review. So this is just a guidance tool. So depending on your research question, then we need to decide on what kind of studies will be included in our review. For example, if you are looking at incidence, so we very well know that incidence could only be got from the cohort studies or longitudinal studies. So your inclusion criteria should also be those which are having a cohort study as their study design. So if you are looking at prevalence, then it could be a surveys or a cross-sectional study. And more often, evaluation of an intervention, either a drug or a vaccine or a behavioral intervention or a screening test, or looking at the long-term outcomes of your cancer or any disease condition. So these data usually come from clinical trials. So they are the gold standard of interventions. So we need to look at only clinical trials to consolidate evidence about therapy or screening or diagnostic accuracies. If you are looking at survival or prognosis, then you can also look at cohort studies. And if you are looking at etiological association, to know the association between the cause and the effect, then we go for our conventional cohort or case control study designs. Only these study designs will be included to know the etiology. Of course, we will not be including cross-sectional studies when we are looking at effectiveness of the intervention, or you want to know the etiological association between an exposure and an outcome. Again, we'll quickly go through some of the questions because framing research question may be the most difficult part to begin with. But then it becomes simple when you understand the PICOD, that is the population, intervention, control, and the outcomes and the time. So this is some general structure wherein you can always specify it like among whom you are planning to do this study, what intervention you are trying to do, what is the outcome you are trying to look at, what are you going to compare the outcome, the intervention against, and over what time period you're going to do. So if you put in all these words together, the PICOD, then you get your research question. Okay. So this is one example where in nursing home residents, that is elderly persons who are receiving nursing care and having osteoporosis. So hip protectors. So hip protectors are a kind of plastic device worn around the hip to reduce hip fractures. So wearing those devices is going to result in fewer injuries from slips or falls. That is the outcome we are trying to look at. Fewer injuries from falls compared to the standard osteoporosis drug. So the otherwise the standard of care would be giving an osteoporosis drug therapy. So here we have put in together all the PICOD and then we have developed our research question. So one more example we'll see, and then before moving to the next step. So this is a research question to assess the association between secondhand smoking and developing breast cancer among female non-smokers. So here you need to be focused that the research question here is very, very specific. The population they are trying to study is female and those who are non-smokers. Basically, the outcome, which is developing breast cancer, can be different among smokers and non-smokers. Here they are not bothered about smokers, but they are looking only specifically at female non-smokers. And what is the exposure or the intervention they are trying to study? It is the daily exposure to secondhand smoke. So that becomes your exposure, and your comparison group is without daily exposure to secondhand smoke. That becomes your comparison group. And what is the outcome they are trying to study is the incidence of breast cancer. So this is a very specific researchable question. So the next step in doing a systematic review would be to frame the eligibility criteria so as to know what studies to include in our review and what studies to exclude. So eligibility criteria we see here is very similar to the eligibility criteria we use in our primary studies, either our case control or cohort studies, where we have our inclusion exclusion criteria to specify which participants to include and which participants to exclude, isn't it? Similarly, we have the inclusion and exclusion criteria to include or exclude the studies which has to be included or excluded from the review. So that is what the only difference here I see. Again, the criteria are going to be very similar to the criteria we use in our primary studies. And a note of caution, as we would avoid mirroring in otherwise also. The exclusion criteria applies to only the subset of those who satisfy the inclusion criteria. So the first the studies or the studies have to fulfill the inclusion criteria, and among them we need to specify the exclusion criteria for not including in the study. Let's say if I specify the inclusion criteria as those studies which are done after 2020, so it is all readily understood that you won't be including those studies which were published prior to 2020, and that need not be specified in your exclusion criteria. So that is called mirroring. You should avoid mirroring in your exclusion and inclusion criteria. So why it is important to have an eligibility criteria? So when we have have a research problem in question, we have a whole lot of literature available. That is, a whole universe of literature is available, and when we look up for these articles, and we end up getting a subset of these articles which are actually available in the universe. So what we get by searching is only a subset. Of course, we will not be able to reach each and every literature or the journal article which is published on the topic. And there are also other grey literatures and reports which are not accessible to us. But even within whatever we obtain by searching using the steps which we will describe later on, whatever we have obtained by searching, we need to filter them based on their eligibility criteria, so that whatever resources we are pulling out, that should be very much close to answering our research question. That is, they should be those articles which are very much pertinent to answer the research question. So that is the process of retrieving the articles, but then having a clear-cut eligibility criteria. So I will exclude those articles. I will be including those articles which are matching this eligibility criteria. That we should be clear. So how to go about and getting this eligibility criteria? Again, it boils down to our P-code format, wherein we need to specify which population we are going to include. So whether you are going to do the study in the children, or among adults, or among elderly, or in a subgroup of population. So whether I'm going to include both males and females, or I'm going to look specifically at women, whether I'm going to look at all religion or all race, all ethnicity, or I'm going to specifically do this that include only a particular ethnic origin. And most often we would be our research question will be focused on a particular health problem. So among patients with diabetes or among patients with COVID. So this put together will form the population criteria. So whether I'm going to do it on adult or children, on diabetes, on a specific disease condition, so this becomes my eligibility criteria pertinent to the population. The next step would be, what is the intervention I'm trying to assess? Whether my studies, they should be using insulin as the intervention, and they should be using metformin as the comparator. So I need to specify what is the intervention and the comparison group which I am going to assess in my study. So that becomes the second criteria. So what is the intervention? So this could be very specific. For example, a particular drug given at this particular concentration over this many weeks or this many days. So that becomes your intervention, and you clearly specify that I am looking at this particular placebo as a control group, or this particular drug as my comparison group. So that needs to be very much specific in the inclusion and the exclusion criteria. The other inclusion criteria could be the outcomes, how the outcome is assessed. So there could be more than one outcomes when we are looking at the effectiveness of the intervention. Like let's say if you are looking at the effectiveness of COVID vaccine, I could be either looking at the effectiveness, that is the reduction in the COVID incidence, or I could also be looking at the adverse events following COVID vaccination. So there could be multiple outcomes from the same intervention. So I need to be very specific. What is the outcome I'm trying to assess? Whether I'm looking at the effectiveness or I'm looking at the adverse effects. And then some of the research questions. For example, what is the prevalence of tobacco use in India? Or what is the prevalence of diabetes in India? So these kind of research questions should be focused only to those articles which are published and conducted in India. So we may have to limit our search results to those articles from India. So we cannot include those articles which look at prevalence of diabetes in US or Africa. So that is another criteria to limit. Then I can limit my studies by calendar period. So let's say if there is a disease and a lot of advances have happened recently in the either in the form of diagnosis or in the treatment of a disease. So I don't want to include those studies which are done prior to 2010 because the entire treatment modality of a particular cancer has changed drastically over the last 10 years. Then now I want to look at the survival of patients with a particular disease condition. If I try to include those studies which are older than 2010, then I may get a different results which is far from the truth. So I would limit my search results only to the last 10 years. So that may be an inclusion or exclusion criteria. Then the type of study, this we have already discussed, what type of study designs to include for each of the research questions. So depending on my research question, I will be including only randomized control trials or observational studies without cross-sectional studies. So that could be specified. And one more limitation is the language in which the article is published. So even now, less than 50% of the articles are published in English. And there are so many regional journals which publish in their local language. So we may not be able to get the evidence which are published in languages other than English. Or we may not be able to understand and interpret the articles which are published in languages other than English. So that becomes a inherent criteria. So when we did a systematic review in of COVID severity, so we were able to include articles only on English because at that time most of the articles were published in the Chinese language. But then we have to get the help of a Chinese person, translate those articles and then retrieve the data. So that becomes one of the limitation or the criteria for limiting the study. So here are some examples. Okay. This is a study to find association between factors and mortality among COVID patients. So among those patients who are admitted for COVID, what are the factors which are associated with the mortality? So when we did this study, we came up with the following inclusion and exclusion criteria. So we included patients. Of course, the population would be those patients who are microbiological confirmed COVID infections. And the study design we are looking at is observational studies because mostly a cohort kind of studies. And we limited the studies which are published up to May 7th. And we included articles only in English language because that time we didn't have a Chinese translator. And we included studies only peer-reviewed academic journals. Those studies which came in the preprints were not included, basically because of the quality issues related with the non-peer-reviewed manuscript. So the exclusion criteria would be if the studies were conducted in a specific population, let's say people with liver diseases or people with the nephrotic syndromes undergoing dialysis. So those kind of studies were excluded because we are looking at the risk factors in the general population. And we were looking at the outcomes of either disease severity or the disease mortality. So if those studies or the cohort studies which have not reported the outcomes separately for people who died and survived, or those people with severe disease and non-severe disease. So we do not, if we do not have the outcome in the way we want, then those studies will be excluded. And most often what happened is, this primary studies will also be part of a larger centralized databases of national health agencies or university databases. And what they do is they publish the database results also along apart from the primary studies. So we don't want the studies to be duplicated, the same data to be coming from more than one sources. So we excluded studies from those which came from centralized databases. So this is a typical inclusion and exclusion criteria. So we'll also look at another example. let's say if you are going to study the efficacy and safety of COVID vaccines, what is the efficacy and safety of COVID vaccine? So my inclusion criteria would be healthy men and women, but non-pregnant women more than 18 years. So this is the population criteria. And they should have received COVID-19 as the vaccination or as the intervention. And the study designs we will include would be only randomized controlled trials and blinded trials. So it goes out without saying that all the other study designs like cohort and case control will be excluded, even though this information will be available elsewhere also. And the trial result should be having one of these outcomes, either the effectiveness or the adverse events, the local adverse events or systemic adverse events or zero conversion rate. So if any of these outcomes are reported, then it will be included in the review. Again, exclusion criteria would be non-English languages and apart from Chinese and English language. And if one study is reported more than once or in two different publications, then that will be excluded. So now that we have gone through the review question and the eligibility criteria, that is the inclusion and exclusion criteria, the next step would be to perform a literature search and how to get the articles from our literature search. So let's say we have picked up our research question and then we have framed our inclusion and exclusion criteria. Now the next step would be to go and retrieve the articles. So where we will be looking for published literature. So we know that there are specific journals which publish articles on a particular topic. For example, if I'm doing a systematic review on tuberculosis, I will be going to a number of journals which have published a lot of tuberculosis related research. For example, International Journal of Tuberculosis and Lung Diseases, Lung India, Indian Journal of Tuberculosis, International Journal of Tuberculosis. So a whole set of tuberculosis related journals I will be looking at, and then there will be hundreds of issues, volumes. I have to go through each of this, or I could search the subject specific journals using a search engine and then retrieve articles pertaining to my research question. So that is one way of doing it. But then what happens is we may not be able to cover all the journals which are publishing on tuberculosis. And sometimes what happens is these articles may also be published in non-specific journals, okay, like Lancet, or this may cover a wide variety of topics. So if TB article is published in such a kind of journal, then we will tend to miss out. The next step would be to go for the cross references. Whatever important articles you have already retrieved, you go back to their bibliographic citations and then see if any more articles on the same topic are published, which may be relevant to our research question. So this is called cross-referencing. From the existing set of articles, we go back to the bibliographic references and then get more articles by cross-referencing. Third type would be to search in electronic databases. By far, this is the most commonest and widely used method for conducting a literature search, because we will have access to all the published literature through a number of databases. But there are also some limitations. Most of the databases are paid and required subscription. Very few databases are freely available. And the fourth possibility would be to look into the grey literature. So there may be a number of unpublished articles, theses, government reports, government data which is lying around, but we may not have it in an organized form. So it is often very difficult to have access to this grey literature. But also the limitation is, if the article is unpublished, then we are not very certain about the quality of the data which is lying around. So this is like a double-edged sword. We need to take into account this grey literature, but we need to be cautious about how much of it we should be including. And of course, the experts in the field, you talk to the people who are experts in the field and look for sources where you can get articles pertinent to the research question. So these are the different modalities. And moving on, we would have come across these terms multiple times. We would have come across Ovid, Cochrane Library, Medline, PMC, Pubmed, Sinhal, Scopus. All these things we would have come across. But we most often do not make a very clear distinction between what is a database and a search engine. So database is a organized and structured collection of all the articles, and these articles are indexed within a database using a particular criteria. So that is what a database. Database is a collection of these articles. So it can be in the electronic form or it can be in the physical form. Now we are talking about electronic databases. The search engine is a tool, okay, like we have a Google search. So the search engine is nothing but a tool which can help us to search the database. So the database is a voluminous collection of articles. And how to search this database? This database is organized in a specific formats, okay, by the type of disease, the date of publication, who is the journal publisher, okay. So this is how the database is organized. And if you want to retrieve some results from the database, we should use a search engine. And this search engine is a tool which helps us to retrieve from the data. So as you can see, those which are above the line are the search engines and those which are below are the databases. So you can also see that we can search a particular database through more than one search engine. For example, Medline is the database that can be accessed from both Ovid as well as Pubmed. And there are also several databases which can be accessed through different search engines. So this is a gist of all the databases and what information is available under them. So if you are primarily looking at medical and public health research, then I think we should go with MBase. It covers all aspects of health and clinical medicine. Sorry, Pubmed and MBase. So Pubmed is good for the American journals and MBase is more of European studies. So it's from the Elsevier. If you're looking at nursing and allied health specialties, then you should look at the Sinhal database. If you are looking at interventions, okay, RCTs, and you want to do a systematic review of the interventions, then you should definitely look into Cochrane library. And if you are looking at psychology or psychiatric information, then you should look for PsycInfo. Social sciences and humanities, qualitative studies, then you should look at the Web of Science. So this is only a outline, but of course there will be always overlap of information between different databases. The same article may be indexed in both Pubmed and as well as MBase as well as Scopus and Sinhal. So this is only a different kind of databases. Of this, Pubmed is freely available. So Pubmed is free available, and there is a subcomponent called Pubmed Central PMC, which gives free full text as well. Otherwise, Pubmed only gives the results of the title and the abstract, and the Pubmed Central gives the free full text as well for the articles. So all of us would have been familiar with this Pubmed. So this is a new portal for Pubmed, wherein we can search for different. So how do we go about searching the Pubmed? So let's take a simple example of searching in Pubmed. So before searching, we should develop a search strategy. So what is the search strategy is? We need to put in a lot of keywords together, and then we need to search. For example, if I am going to do a systematic review assessing the effectiveness of brief intervention for alcohols. So I am interested in assessing the effectiveness of an intervention which is giving brief intervention for alcohol dependence. So what is the effectiveness? Whether following the brief intervention, whether the alcohol intake is going to come down, that is what I am going to study. So if that is my research question, so then I need to come up with a list of keywords I need to enter into the search. So you can see the search bar in the Pubmed. So in this we need to enter the terms, and then the Pubmed will search for these terms, and then it will give us the results. So how to do a search? So we need to search with keywords. So what are these keywords? These keywords are nothing but our picot split into different components. We need to develop our keywords as per our picot. What is the population? What is the intervention? What is the comparison? What is the outcome? What is the study designs? And what is the timeline? That is how we will generally split up the keywords. And the next point would be whether to search with the keyword directly or whether we need to do something called controlled vocabulary. So this controlled vocabulary is nothing but using mesh terms or M-tree terms. So some of us would have been familiar with this mesh term. It's nothing but a medical subheading. When you look at the way the articles are organized within Pubmed or the Medline database, they are categorized one below the other under a major heading and then a subheading, and then within that. So that is how the books are generally arranged in the library, isn't it? So there will be a broad field, and under that there will be a lot of subclassifications, and within that there will be subclass. Likewise, in the Medline or any other database also, all these articles are indexed as per the topics. So a controlled vocabulary or the mesh term, medical subject heading, means that a particular article, if it talks about tuberculosis treatment among children, then it will be indexed under children, under tuberculosis, and then under treatment for tuberculosis. So that is how it will be put under. It is like where this particular article goes in the whole system of arranging the digital platform. So that is the mesh term about. So how to know what is the mesh term for a particular term? Then there is something called mesh search. So we need to go and enter the term, the keyword, into the mesh search, and then it will tell us what is the mesh term for the particular key term. So that is the one aspect to use a mesh term or a controlled vocabulary. I will show you what is the difference between using a mesh term and directly entering the term into the Pubmed search engine. Then the next step would be to combine the search terms using a Boolean operator. So these Boolean operators are nothing but how to combine two different concepts or search terms using and or not. So by combining two search terms using and or using or and not, that will help us to narrow down or expand our search results. And then there are also other filters based on the inclusion and exclusion criteria. Like we said, we can limit based on the period in which the article was published or the language in which it was published, what is the type of study designs. Okay, so there are these filters, so we can apply to the articles and refine our search strategy. So we'll see some examples of the search strategy. We cannot go in depth about all these aspects, but just we'll see a glimpse of it. So in the first example, I have searched the term tuberculosis, okay, and then I have got 276,000 results. So this means Pubmed has searched this term tuberculosis into the database, and if this word tuberculosis appears anywhere in the article, okay, even in the introduction or in the results or in the references, then the particular article will be pulled up and then shown as a search result. So that is what this searching in all fields about. If you do not specify anything and then just simply type tuberculosis in the search bar, then this is what is going to happen. It is going to give a search result in the all fields. The next step would be to use a mesh term. So I went to the mesh browser and then I searched what is the mesh term for tuberculosis. It is still the same. Tuberculosis is also the mesh term. So the moment I specifically mention the tuberculosis within bracket mesh, the number of results which it is giving is only 2 lakh results. Basically, I have screened out 76,000 articles. I have removed 76,000 articles from my results. Basically, because these 76,000 articles may not be about tuberculosis, but it contains the word tuberculosis somewhere in the article. Okay, so what this mesh does is it only identifies those articles which talk about tuberculosis rather than containing the word tuberculosis. If you just make a simple search without any terms, mesh terms, then it takes up those articles which mention tuberculosis anywhere in their article. But if you specifically mention mesh term, then it will retrieve articles only which specifically talk about tuberculosis, and that is why the search results have narrowed down to 2 lakh from 2,76,000. And the third type is we can also search for this particular term, tuberculosis, in particular field of the article. For example, you can search for this tuberculosis term in the title and abstract. So if I specifically mention I should have this word tuberculosis in the title, then it is more likely that the article is on tuberculosis, isn't it? So I will specify that you look for this term only in the title and abstract, not anywhere else in the article. So that is yielding me a result of 2.25 lakhs. So slightly more than the mesh term. So this is one way of narrowing down our results by using mesh terms or specific searching in specific fields like title, abstract. You can also search based on the author name in a specific field. or the name of the journal or the type of publication or place of publication. So we can have all these searches depending on the fields. The next aspect is to use a Boolean operator. So this Boolean operator, there are basically three operators: or, and not. So what happens is when you want to tell the database that you want articles that contain either first term or the second term. Or in this example, we have smoking and nicotine. So let's say the first circle represents those articles which talk about smoking, and the second circle represents those articles which talk about nicotine. So if you combine both the terms using or, it will give you a search result which contains articles both, either on smoking or nicotine. If either one of them is present, then that article will be shown in your search results. That article will be retrieved and shown to you. So that is the usefulness of using or, both smoking or nicotine. If either one of this is present, then that will be shown in the result. Instead, if you combine them using and, what happens is it will only specifically yield the results which talk on those articles which talk on both smoking and nicotine. So the article should contain information on both smoking as well as nicotine. If both are available in the same article, only then the article will be retrieved. That is the intersection portion between the smoking and nicotine. So this is the function of and. If you use not as a Boolean operator, what it does is it retrieves articles on smoking, but specifically excludes a subset which talks on nicotine. So it will only show those articles on smoking without nicotine. So that is the function of not. So what is the usefulness of this Boolean operator is? This Boolean operator is we can narrow down the searches using a combination of this search Boolean operators. For example, I have to do a study which looks at effect of smoking or nicotine on cancer. What I do is I am going to include smoking or nicotine. So intersection of both these two along with cancer. So it will be having articles on smoking or nicotine. So this area which is intersecting with the cancer. So the green shaded part will be shown. So likewise, we can use any combinations of the Boolean operators and we can expand or narrow down our search. The next aspect I told was the field search. We can go to the advanced search in the Pubmed and then we can look at any specific fields. For example, the name of the journal or the author name, the publication date, any terms. There are a whole lot of fields which you can search and then we can narrow down our search. So these are the broad principles of searching and retrieving articles in the Pubmed. So how to develop a search strategy? So for the same topic which we were discussing, let's say about the brief intervention for alcohol. So my population would be persons with alcohol dependence or persons with drinking problem. So that is my primary search term. But I cannot just search with a single term, isn't it? Because different people would have written differently in their articles. Some would have used alcohol related disorders. Some would have used alcohol drinking, alcohol intoxication, alcohol abuse. So all these things are synonyms. But different people would have reported differently in their article. So now how to get all these articles together? So that is where the mesh term helps. Because whatever the author has used, still these articles will be indexed under the alcohol drinking. So all this alcohol drinking, alcohol abuse will still be indexed under the same mesh term. Thereby it makes our work easy. Another way is if at all it has escaped the mesh indexing, in case some of the articles are not indexed under the alcohol drinking, then what happens is we can still do a related search of terms. Like in this example, you can see alcohol, the word alcohol, if it is present anywhere near the word drink or intoxication or abuse or withdrawal or consumption, then a particular article will be retrieved and then shown. So this word alcohol along with drinking or abuse should be present anywhere in the title or abstract within a three words limit. So that will be retrieved and then shown. So you can see what is this asterisk next to drink. So this asterisk is called truncated search, which means Pubmed will search not only the term drink but also drinking, okay, drinker, any word which has the initial 5 letters as drink. For example, intoxicate, intoxicated, intoxication, okay. So consumption, consumed. So all these words will be shown in the results. This is called truncated search. So near/3 means anywhere between alcohol within next 3 words. If drink or intoxication or abuse is found, then that will be retrieved and shown in the results. So these are all some kind of advanced searches wherein you can include more number of articles to match your search criteria. And of course, you can see here TI, AB, which means title or abstract. I want this word to be present in the title or abstract. Then the next part of the primary search term would be the intervention, which is the brief intervention. So you can see there are lots of synonyms for brief intervention, like brief psychotherapy, psychological interview, behavior therapy, cognitive therapy, motivation. So these are all synonyms, and which different authors would have used different terms for meaning the same brief intervention. So I need to put all these mesh terms into the search strategy, and then I could also use intervention, therapy, interview in the title and abstract. Okay. So now I bring in one more concept. For example, these are the different terms, isn't it? These are the different terms: alcohol-related disorder, alcohol drinking. So when we are doing the search engine, how do we want to combine these terms? You want to combine alcohol-related disorder and alcohol drinking, all these terms using and or. We should naturally go with or, isn't it? Because a particular article which talks on alcohol-related disorders or alcohol drinking, if any one of these is satisfied, then still it should be shown in the results. So I would combine within a particular concept, that is population, I would combine all the search terms using or. And across different concepts, like I want to combine this population with this intervention, then I would use and. That is, I want articles which look into alcohol-related disorders or drinking, all these things together. And also it should have information on brief intervention, psychotherapy, and all the related terms. So within a particular concept, that is intervention, you should combine using or. And across concepts, you have to combine the population with the intervention using and. So that is the usefulness of using the Boolean operator. And then other search terms could be the comparison group. So here I have not put any terms because I want to compare it with the no intervention. Most often what happens is if at all they are going to compare it with the placebo or no intervention, they may not mention it in the title. So if you are going to limit the search using the terms no intervention, you may not the word no intervention may not feature in the title. So thereby you may miss out on the articles. So we do not include those in the search term. But if you have a comparison group as another drug or another behavioral intervention, then you should again go about and include that term in your search strategy. Again, the outcomes what we are trying to look here is reduction in the alcohol intake. So when you are trying to compare the effectiveness of intervention, I may have more than one outcomes. For example, reduction in the binge drinking episodes or reduction in the quantity of alcohol consumed. So if you are very specific about your outcome, then you go about and include the outcome in your search strategy. If you are not very specific about your outcome, I am trying to include all the outcomes which are possible, then I would not specify them in my search strategy. So it is up to us, depending on the research question, to specify or not specify in the search strategy. But this is important for me. I am trying to evaluate this evidence in the primary care setting. So what is the effectiveness of brief intervention, not in tertiary care, but whereas in primary care setting or primary health centers. These are the different synonyms for primary care, community health service, community physicians, family physicians, primary care physicians. So these are the different terms I should use for defining the setting. And of course, I will combine all these terminologies within this concept using or. So that if one of these is featured, it will be retrieved in my result. So this is how you develop a search strategy before putting it into the Pubmed. So you need to develop all this into the Pubmed, and then you need to put into the this search strategy into Pubmed and retrieve the article. So this is the one of the crucial steps. So depending on how you choose your search strategy, the sensibility of your search is going to be. So if you include all possible combinations, then your search is going to be more sensitive and including all those articles which are pertinent. But you cannot end up screening thousands of articles also, isn't it? So you need to narrow down to those which are meeting your specific research question. So you need to also keep in what are the limited what are the filters to apply for your search strategy. I want to include only RCTs only published during this particular year. Okay, so this is one another example. So wherein we have tried to put in all possible names for COVID virus. So when we initially planned in 2020, so different articles are reporting different terminologies for the same COVID virus. So we try to include as much as possible. So increase the sensitivity by including all the different forms for COVID virus. So we were in the mid of the lecture. I hope everyone started with great enthusiasm, and then halfway during the meeting somehow we are lost, isn't it? Because it's a very extensive topic, and we need to understand what we are doing in each and every step. I hope people are not like this. Something has gone into till now. So going back to the steps, we have already seen how to conduct a literature search and how to develop a search strategy. The next step would be to retrieve these studies and then do the systematic review. So this is the fourth step. So the next step, we need to choose the tools what we are going to use. So till now we have been doing in Pubmed or the different databases and search engines. So now we need to have some tools for doing the systematic review. We can also do the same steps manually also. We can manually download the results from Pubmed and then screen one by one. But it would be cumbersome when you have thousands of articles and hundreds of articles to screen and then hundreds of articles to do the full text screening and then extract data. It becomes very cumbersome. That is why we suggest you to have some tools. So there are some free tools and then some tools are paid and require subscription. So one of the free tools is called Ryan, okay, RYAAN. Ryan, it's a free software which can be used for screening, for eligibility screening, full text screening, but not for data extraction. And there are some tools which can be used for data extraction, bibliographic management, and even analysis, like Revman. Revman is also a free software. There are some softwares which offer all the services, right? Starting from importing the search results, title and abstract screening, full text screening, bibliographic management, data extraction, and analysis. So Covidence is one such software which offers all these services as a single package, but then it is a paid software. So for beginners, I would suggest you go with Ryan for screening, and you simply use an Excel sheet for data extraction. So that is about choosing our tools. So what it does, we will see in the next steps. Why we require this tool, I will show you in the subsequent slides. But you understand that we need some tool to do this systematic review because doing it manually will be very cumbersome. The next step would be, now that we have searched the Pubmed, we will end up with a particular number of results matching our search strategy. So how to go about from this step to screening and data abstraction. So the next steps would be to import the results into a particular software. So that would be the next step. And after it is imported, then we need to look at the title and abstract and then screen the articles for relevance. So the first step would be to just simply read the title and maybe the abstract and then know whether the particular article is relevant for our research question or not. So that is called just a screening from the title and abstract. So if by reading the title and abstract you are satisfied that this article is related to our review question, then you take it up further in the process and then you send it to the next step called full text screening. In the full text screening, you read the entire article and assess the article in depth, okay, using your eligibility criteria, inclusion and exclusion criteria, and you see whether all the required details are there, and then you select the article for including in the review, final review. So once the article is included for the final review, it means it has satisfied all the eligibility criteria and it has the required information in the required format. So it can be used for extracting data and then presentation. So the last step would be to data coding and abstraction of data from the individual article. So this is I have just put a demo wherein you can see I have searched the terms brief intervention, alcohol, and primary care. So this is not the way how it has to be done, of course. You have to broaden your search using different mesh terms and different synonyms, and then you have to come up with a comprehensive search strategy. For the sake of demonstration, I have kept a simple search strategy, and then I have searched in Pubmed. You can see there are 727 results. So I have to go through each of these 727 articles, and then I need to, look up what are those articles which are matching my eligibility criteria and what are those articles which are not relevant to my relevant research question. So how to do that? So I can just simply export this from Pubmed, and then I can send it to different software. I will just show a demo of that, a brief clip. Okay. So you can see there search strategy and 727 results. I can save this result in the form of a CSV file, and then I can click create file. You can see the Excel file is downloaded here. Okay. There is also another way of doing it. You can go to send and then send it as a citation manager. Okay. You can select all results and then create the file, and the file will be exported in the NBIB format. Okay. So these are the ways in which you can export the search result to either a CSV format or the format citation format. So you okay. So one way is you have to go to the send, and then you have to send it to citation manager. You will get this file downloaded. So this file can be imported to the next step for taking it forward. Okay. So this is the opening screen of the Ryan software. This is the free software I told. Okay. So this does not require any paid subscription. So once you log into Ryan, so you will get a screen like this. There you can see my reviews, the list of all your reviews. You can also collaborate. Of course, you have to collaborate with more than one person for doing a systematic review, like the previous speakers said. So when you click the new review, it will ask for the title, and then what is the research field, what is the type of review, and review domain. So once you fill these details and give a description, it will take you to the next step of creating a review. And subsequently, we will also see what are the how to import the exported review from Pubmed into this particular software. So it is very simple. So now you can see that a new review has been created in the term alcohol brief intervention, and then it is asking to upload references. So this upload references, either you can upload the CSV file which you have downloaded, or you can upload the NBIB format. Okay, the format of references. Sorry about it. Either you can upload the CSV file which we downloaded from the Pubmed, or we can also upload the citation manager file from the Pubmed. You can directly upload into this Ryan software. So you can see what are the different file formats here. Okay, so you can see these are the different file formats which you can import. EndNote, reference manager, BibTeX, CSV files, Pubmed, XML, all these files can be imported. So basically any reference manager or bibliographic file can be imported into Ryan. Okay. So once I upload, let's say I have downloaded the file from the Pubmed, so that I'm going to upload into the Ryan software. So this is the CSV or the NBIB format. I'm just clicking OK. So now you can see there is a taskbar where you can see that file has completely uploaded. Now it is asking to continue. So you know this file has been uploaded and it is asking to continue. So once these references are imported, you can see this is the screen, the main screen for Ryan software. So here you can see the name of the systematic review, and you can see there are 204 new articles which were imported. Okay, so the file which I exported from Pubmed was imported into this software. So you can see here, this is the inclusion decisions. So none of the articles we have included or excluded. So it is still pending for inclusion or exclusion. And the software automatically categorizes based on the study designs and also some of the keywords. Sorry. And you can see the list of all articles which are imported in the top portion of the window, and the individual articles are shown in the bottom half. So this article about alcohol-related nurse care management in primary care, you can go through the abstract and then title. And if you find that this article meets your is eligible for including in your review, based on the title and abstract, then you can either click include, or if you feel that it is not meeting your eligibility criteria, then you can put it as exclude, or if you are doubtful about it, then you can give maybe. So these are the three options which are available. So you basically read through the title and the abstract, and then you decide whether to include that article or exclude that article, or if you're doubtful, then you mark it for further review. So this step has to be done independently by two people. So the same 204 articles will be reviewed by two independent authors, and they will decide on the eligibility criteria. And there will be a third person to moderate or arbitrate the mismatches. Let's say the first person says include and the second person says exclude. Then the third person has to review those articles. Okay, this is called the mismatch or the conflicts. So this conflicts will be resolved by another person, and then finally they will take it up. Okay, this matches the criteria, and we will take it forward for the next step. So that is how we will go about and do the title and abstract screening. So we have to do this by two independent persons for all the 204 articles, and subsequently you will be marking it as included or excluded, and all the individual articles will be tagged. Then we can know what are those articles which are included by both the persons or resolved by the third persons, and then we will take only those articles to the further steps for systematic review. I hope this is clear with respect to title and abstract screening. So out of the 252 articles, okay, only 53, okay, you can see here it is shaded, but it is still visible. You can see here 53 have been included for the review. So out of the 253 odd articles, okay, only 53 have been based on the title and abstract screening. Only 53 are matching eligibility criteria for inclusion. So we will take only these 53 to the next step. So this 53 articles alone can be exported to any of the reference manager software, either Revman or reference manager or BibTeX, EndNote CSV file. If you want it as a Excel file, also fine. You can export it to any of this and then give export. So it will give only those list of 53 articles which are directly related to your research question based on the title and abstract screen. There is also one more problem here. So when you are doing this title and abstract screening, most often you will have to search from more than one database. Okay, you will have to search Pubmed. You will also search Embase, also from WHO databases, and multiple website databases are possible. So in that case, when you are importing into the Ryan software, you will have to include all the 4 files altogether. So simultaneously, you have to include all the 4 files while importing into Ryan. But then the problem is, a particular article may also be there in Embase as well as Pubmed. So it will be imported twice. Okay, the same article is indexed in the both Embase as well as Pubmed. So what happens is it will be imported twice, once from Pubmed and once from Embase. But then they are one and the same article published in the same journal, same authors, everything else is same. What happens is Ryan has an option to detect the duplicates on its own. So here you can see next to this new articles, you can see there is detect duplicates. So it is a kind of artificial intelligence. What it does is it matches for the title, the author's name, the order, the institution, the amount of data and everything. And then it tells that these are the duplicates. And then you can, by one click, you can directly remove all the duplicates if it is exactly matching. But there is also another AI process. If not, entire thing is not matching. Maybe 80% of the article is matching. Okay, some changes in the author or some changes in the title. That will be picked up by Ryan, and then it will ask for your opinion. So to resolve the conflicts on duplication. So you can then manually review the article, both the articles, and then you can decide whether it is a duplicate, and then you can remove it, or you can tell that these two are separate articles, and then you can include both in your review. So that is the kind of facility we have in Ryan software to detect duplicates. And then finally, we will end up with only a single copy of each article, which will be screened for using title and abstract, and then taken forward for full text. So this we have covered. The next step would be to get the full text of the article. So Pubmed does not give full text for all articles. So you can see next to that, each of the Pubmed article, you can see there is a link for full text, either the Cochrane library or the PMC full text. So some of them may be available within Pubmed itself, but some of them may not be available. But then we have to go to the individual full text links, and then we have to get the article. If it is not available, if requires subscription, then you should write to the authors, or you should pay the subscription and get the article. Somehow you should get the full article for all those articles which are which were screened positive in the initial step. So once you get the full text article retrieved from the individual sites or from Pubmed Central, then you should check with the eligibility criteria, whether it is matching the population, intervention, comparison group outcomes, and whether the outcomes are reported as per the criteria. And once all these things are satisfied, then we will include it in the final review. So this is also a labor intense step. So from 1000 studies, we would have narrowed down to 300 studies, but you have to review each and every study out of this 300 and then decide whether they are meeting the eligibility criteria and whether they are eligible for inclusion in the final review. So this is a way of documenting the search strategy. So here you can see, let's say I have searched 3 different databases. I got 100 in the Pubmed, 120 in Embase, and 80 in Scopus. Let's say I put all these things together. I have identified 300, and I have also done some cross-referencing and then bibliographic. I have cross-checked, and then I have got 30 more articles from cross-reference. After duplication from the 330 articles, after removing all the duplicates from the 3 different databases, I have only 170 articles, original ones. And then I have screened all the 170 articles, and I have excluded 130 articles such that from the title and abstract, I feel that it is not directly related to my research question. So I have excluded 130, and I have included only 40 articles for the full text review. Okay, so I have excluded 90 articles. So I should write what are the reasons for excluding. So from this 130, what are the articles not meeting the eligibility criteria? Then I should also write what are the reasons for excluding from the full text review. Okay. If these 40 articles are going to be used for the full text review, not all articles will be used in meta-analysis. Only 28 articles from this 40 will be eligible for including in the meta-analysis. So that is not part of this, but still, if a subset of this will be eligible for meta-analysis, that you need to mention. So the same data will be represented in the form of a flow chart, which will be covered in the next session by Dr. Rivaraj. So how this identification, screening, and eligibility will be reported as in the form of a Prisma flow chart will be dealt in later. But you need this data at each step, how many articles are there, so that you can develop that Prisma checklist. And the last part, actually, this is about handling the results and keeping track of the articles. So once we do the full text screening, it is important that we maintain these articles in a bibliographic manager. Okay, either reference manager or EndNote or Zotero, whatever is the reference manager, you have to maintain the articles so that it is easy for you to retrieve at each step. So what are the information we are going to include from retrieving the studies? So it says, Cochrane handbook says that we have to collect characteristics of the included studies in sufficient details to populate a table of characteristics of studies included. So basically in the result section, we are going to talk about the characteristics of the studies which we have included. So we should have sufficient information about the studies which are being included. So what are they? So we have to consider retrieving the following information from the full text articles. So who is the data extractor? When was the data extracted? What are the identification details of the person who is doing the data extraction? Because later if some error is there, then we can always go back and cross-check with the information. The next would be the eligibility criteria, whether the study meets the eligibility criteria in terms of PICOT. If it is not meeting, then we should note down the reasons for exclusion with the reason why it is being excluded. So this is the criteria which it is violating. That is why this study has been excluded from our review. So this is important for all the full text articles. Okay, the eligibility criteria and the reasons for exclusion, and this needs to come out in your Prisma flowchart. So what are the other information which we will be retrieving from the studies which are included? The study design, whether it is a single-centered or multi-centric study. If it is multi-centric, how many centers are participating in your study? What is the recruitment and sampling procedure? Because different studies may adopt different sampling procedures. And later you may have to do a subgroup analysis based on the sampling technique or the recruitment process. So this information should be collected. When the enrollment was started and when it was ended, what was the period of follow-up? Because different studies will have different length of follow-up, and that may have an effect on the outcome which you are trying to study. The entire details about randomization, how it was done, how the allocation concealment was done, what kind of blinding was done, whether any method was taken to account for selection and information biases, how controlling of confounding was done. So all this information on the method section should be included as part of the data extraction form. And then if any missing data is there, how it was addressed. So these things should also be part of the data extraction form. In statistical analysis, you should know what is the individual of study in the what is the unit of analysis in the individual study, how whether crude estimates were reported or adjusted estimates were reported, what is the source of funding, and what is the financial relationship between the authors and the funder. So this also needs to be taken into account. Then moving on to individual components, whether the participants, in which setting it is done, which region, what is the eligibility criteria or the diagnostic criteria. So some would have done with RT-PCR, some would have done with the RAT. So even though we say it's COVID-19, there will be different criteria to label them. So that we need to take into account. And what are the characteristics of the participants? The basic characteristics. What is the mean age? What proportion were males? What proportion were females? How many had comorbidity? Then information about intervention. So when you are doing a trial, review of the trials, then we need to document the description of the intervention in detail. Because even though we say it is a drug or a vaccine, it could come in different forms, different doses, different durations. Okay, how much the patient was adherent to that, whether the staffs were trained in giving the intervention. Okay, even though we say broadly as a brief intervention, whether it was provided by doctors or nurses or healthcare workers, or what is the qualification of the staff which are provided, how much training they had received, all these things also makes a difference with respect to the outcome. So we need to monitor all these aspects of the intervention when we are trying to collect the data from the individual article. Even though we say it's a control group, what was given, whether a placebo was given or a poster was given or a health education was given, a different kind of intervention was given. So these things needs to be accounted in the data extraction. And coming to the outcomes, like I said before, there could be more than one outcomes, and we need to be very specific about what is the outcome and how it is collected. For example, anxiety itself may be collected in different forms. Different tools are there, different scales are there, and how this scale was administered, was self-administered, or because anything you think you have in mind that could affect your outcome. So this is going to affect my outcome. That is a variable which I should be retrieving in my data collection tool. And of course, you may not collect all this information in all these studies. So this is not a general checklist or a general tool which you should collect for all studies, but these are all different aspects which should be part of your data collection tool. Not necessary and mandatory to have all these things in your collection in your tool. I'll show you one example, like mostly what are the information we are going to collect. So in the result section again, so this is important, isn't it? We need to synthesize the results based on the results. So how many participants were there assigned and at each stage of the study? How many were lost to follow-up? How many completed intervention? How many were available for final follow-up? All these things should come up in your data. And what is the summary measure? Whether it was a mean, standard deviation, or the 2/2 table proportions. And if it is a comparison between two groups, then what is the effect size? What is the precision? And if any subgroup is planned, then that information on the subgroup should also be collected. So these are the broadly the characteristics which you should collect. So just to summarize, information about who is doing the extraction, the eligibility criteria, the study methods and the components within the methodological aspects, what needs to be accounted, the type of statistical analysis, the participants, the intervention which we are trying to study, the outcome, the description of the outcome, and the results, whatever is primarily being reported. So this is one table, final table, how we would come up with a table in our analysis. So this again will be covered in detail by the next session by Dr. Yuvraj. But if you are going to provide information with respect to all these things, then you should collect this information during your data retrieval stage. That is what I am trying to make a point here. So if you want to project that the study was based on the continent in which it was done, or which country it was done. So you should collect this and retrieve this information from your full text screening, or if the participant's age or which WHO region it begins. So if you want to portray your results or the study characteristics based on this particular variable, then that should be collected in your data collection, full text eligibility screening, full text screening and data extraction. So that is the point I'm trying to make here. So with this, I think to sum up, you come up with a research question and then you frame your eligibility and eligibility criteria in terms of inclusion and exclusion criteria. You identify the sources from which you have to make a literature search, and then you conduct a systematic search from different databases using a specified search strategy, and then you merge results from all the different databases, and then you try to examine the title and abstract for eligibility screening. And then once the screening is passed, you retrieve the full text of the articles and then link together multiple reports of the same study and examine the full text reports. And if they meet the eligibility criteria, then make a final decision to include the article in your review and proceed to data extraction with the tool as specified. I think that sums up the session and briefly covering the steps in performing a systematic review. The further 2 steps will be taken up in the next session. If you have got any queries, you can post them in the chat box and we are happy to address them at the end of the session. Thank you.
Thank you so much, sir, for an elaborate, crystal clear explanation on the steps of systematic review. So it gives me an extra happiness to introduce the next speaker, since he is my senior in my undergrad school. Is Dr. Yuvraj. Sir have completed his post-graduation in community medicine from JIPMER, and he followed by SRship in JIPMER. And he's currently the assistant professor in ESI Medical College, KK Nagar. And Sir have won the Best Research Grant Award by Joint World NCD Federation, IAPHCon, under the category of Systematic Review and Meta-Analysis in 2021. And he have won 2 Best Paper Presentation Awards. And Sir has been the principal investigator for 6 intramural and extramural funded projects. And he's been a resource person for various workshops conducted in JIPMER. And till now, he have 72 published articles and 31 more yet to be published. And Sir have co-authored for a chapter in a book titled Anxiety, Uncertainty and Resilience During the Pandemic Period. So Yuvraj sir will be speaking on the topic risk bias assessment and presentation of results. Over to you, sir.
Thank you, Dr. Sharath. Can I share my slides?
Yes. Yes, sir, you can share now.
Is it visible?
Yes, sir, it's visible.
Thank you. So, good afternoon, everyone. So, till now we would have seen like what is systematic review, why systematic review is needed, and what are the steps that are involved in conducting a systematic review. So, mine is actually a continuation of the previous session that was conducted by Dr. Gilbert. So, mine will be the last 2 steps involved in a systematic review. That is the risk of bias assessment. And finally, after doing all the steps you have done in the previous 6 steps, how will you finally analyze and present your results? So first we'll see about the risk of bias assessment. So what is this risk of bias assessment? So what we are trying to do here is that we are trying to check the internal validity of a published research. Okay, so you should clearly note that we are checking the internal validity of a study, which is nothing but how methodologically rigor was that particular study was conducted. Okay, for example, if we take an RCT, whether the random sequence generation was done or not, whether they followed an appropriate method, whether allocation concealment was done or not, and whether they followed an appropriate method. Even if we take any observational study where they took a sample that is representative of their study population, or whether they taken an appropriate, they have given proper justification for the sample size they have taken. Like that, we are checking the internal validity of a study. So why we need to do this risk of bias assessment is that even though all the published research undergoes a rigorous peer-reviewed process, it doesn't always guarantee a internal validity of the study. There might be some of the methodologically flawed studies which they might have mentioned in their own limitations itself. Okay, so like that, so such kind of less rigorous studies might tend to overestimate or underestimate the effect. Okay, so that's why we are trying to check the internal validity of the published research by using this risk of bias assessment. Now, what common mistake that occurs is that this concept is getting confused with a term called imprecision or external validity. All these three concepts are entirely different. For example, imprecision means it is having, for example, the study final estimate is having a wider confidence interval. That wider confidence interval might be due to the study might be having lower sample size. Our concern is not that that study had a lesser sample size, so it's not methodologically right. It is not like that. Even though if they, for example, they have taken only 50 as a sample size, there should be a proper justification by giving, for example, a sample size formula or a sample size software that they have calculated and given a justification that why they have taken a 50 sample size. Okay, so we are not looking at how much is the sample size. We are trying to check whether the sample size that are taken in that particular study is properly justified or not. Okay, so that's why the internal validity thing should not be confused with the imprecision part. Similarly, external validity, what it means is that whether we can extrapolate the findings that is that study has reported, whether it can be extrapolated to the entire study population in which it was conducted. For example, there are some it is conducted in particular village, so they have taken only 100 sample. Whether that finding can be extrapolated to that entire village or not, that is not our concern. Okay, so that is an external validity. So the risk of bias assessment, what it does is that it only checks the internal validity, which means the methodological rigorousness of that particular published research. And another thing you should know is that what we are trying to tell is we are checking whether there is a risk of bias is present or not. We are not telling that that study is biased. Okay, we should not establish there is a bias is present. Okay, we can tell that there is a risk of bias since we are not the primary authors who have done that study. Okay, we are taking a 6-page report or 6-page original article that is published, and we are checking using some certain parameters and telling whether there is a possibility or risk of bias is present or not, and we should not establish that there is a risk of bias. Okay, so that is why we need a risk of bias assessment. Another reason why risk of bias assessment is conducted is that in some places, even some authors, they use this risk of bias assessment as a eligibility criteria itself. For example, they will have eligibility criteria that the studies which we find as having high risk of bias, we will be excluding from the final review itself. Okay, so this risk of bias assessment, sometimes it goes behind one step also. It can go behind that data extraction part. During the selection of studies itself, while going through the full text, they will check the risk of bias and see if this particular study is having higher risk of bias. They might even tend to exclude that particular study from the review itself because they want to give more robust estimate or robust analysis. So that's why they might even use this as a eligibility criteria also. So that's why this is an important step. Why is that even if you are going to include that review in that study, you have to further stratify the study and tell that how the studies having high risk of bias are reporting the estimate and how the study having low risk of bias are reporting the estimate. So now we'll move on to what are the tools that are available for the risk of bias assessment. So these tools are actually depends on what kind of study designs you are going to include in your particular review. Okay, for example, in the previous sessions itself, the speakers have told that you can include any type of study designs in your review. You can include an RCT, non-randomized trial, observational studies, diagnostic accuracy studies, even qualitative studies. Anything can be included in a systematic review. You can do a systematic review with any type of study design. Okay, so there is a separate tools are available for risk of bias assessment for each of the study design. Okay. So first, for an RCT, that is for a randomized control trial, there is a tool called Cochrane's Risk of Bias 2 tool. Okay, so this is actually an updated tool which was released only 2 to 3 years back. Okay, so there was actually a previous tool that was there by Cochrane, Risk of Bias tool. This is an updated tool that they have released only recently. That is a Risk of Bias 2 tool. So this is a standard tool which can be used if you are including only RCTs in your review. Okay, there is another tool that is also available, that is a Gilbert scale, that is also being commonly used in Western countries for assessing the risk of bias in randomized control trial. Similarly, for a non-randomized trial, there is a tool that is also released by Cochrane, that is risk of bias in non-randomized interventions. Okay, that is a Robbins I tool, which is also released by the Cochrane, which can be standardly used for assessing a risk of bias in a non-randomized trial. Next is for an observational study. For example, it can be a case control or a cohort study. Any observational study, you can apply any of this tool. That is, there is a tool called Newcastle Ottawa scale and JBI checklist for case control or cohort studies. Similarly, there is a tool that is also for cross-section studies, that is the same Newcastle whatever scale that is adopted for cross-section studies, and there is a tool called access tool, and also there is a JBI checklist for prevalence studies. So there is no hard and fast rule that you should only use this tool and you should not use that tool. Okay, so you can use any of this available standardly available tool for the assessing the risk of bias. Okay, so I'm not going to go in detail about each of this tool. I will just going to explain with an example, that is the Cochrane risk of bias tool. Okay, so I will tell you how you will assess a risk of bias using this tool and how you will finally conclude that particular included study is having high risk or low risk of bias. Okay, because a similar technique only you are going to apply for any of the tool. For any of the tool, whatever the steps I am going to tell, only you are going to follow. Okay, so for example, this Cochrane risk of bias tool has 5 domains. Okay, so the first domain is a bias arising from the randomization process. Okay, so we all know that the randomization process involves 2 important steps. That is generation of random sequence and then allocation concealment. Okay, so what you will do is that you will check for this domain. For example, you will check for these 2 steps, whether that particular study with you have included, whether they have done random sequence generation or not. Okay, so first you will check whether they have mentioned that they have done a random sequence generation. Next thing what you will check is that what method they have used for doing this random sequence generation. For example, a study can report that they have done a random sequence generation based on a simple randomization or block randomization. Okay, so that gives you an evidence that that particular step has been conducted in that particular study. Similarly, another question is allocation concealment. Okay, so you will check that whether the allocation concealment is done in that particular study or not, and what method was employed. For example, the study might report that they have done allocation concealment using a snooze technique, that is sequentially numbered opaque envelope technique, they would have reported. Okay, so like that, if they have reported that they have done random sequence generation using this method and they have conducted allocation concealment using this method, then you will report this domain as having low risk of bias. Okay, so there are 3 options available for each of these things. Okay, there is a possibility of low risk of bias, there is a possibility of high risk of bias, and there is a possibility of some concerns. Okay, so first I told is that if they have reported that they have conducted a randomization, the 2 important steps in randomization process, that is the generation of random sequence as well as allocation concealment in that particular study, then you can report it as having low risk of bias. Okay, so the next is if they have not reported that they have not conducted random sequence generation itself. Because for example, they might have reported in the title as it's a randomized control trial, but when you go into the methodology and see, if you find that as no, we cannot able to conduct a random sequence generation or not able to conceal the allocation sequence, means then you have to report it as high risk of bias. Okay, so it's clear that so if they report that they have done this standard technique, standard randomization process, means you will report as low risk of bias. And if they mention that they have not conducted these 2 steps or any of these steps, means you will report it as high risk of bias. Okay, so what is this some concerns? This some concerns comes into play if there is no mention about the random sequence generation or allocation concealment. Okay, for example, a study may, so you don't know that whether they have conducted or not. They might have conducted a random sequence generation, but they may not have reported in that particular original article they have published. Okay, so or even they would not have done that particular step, so that's why they would not have mentioned about the particular step. Okay, so you're not sure that whether it was conducted or whether it was not conducted. There was no mention about a random sequence generation or allocation concealment. So in such scenarios, what you will put is that there is some concerns with respect to the randomization process. Okay, so that is a difference between what is a low risk, high risk, and some concerns. Okay, low risk means they have reported that they have done those 2 steps properly using standard method. So high risk is that they have reported that they have not done any of these steps or any one of these steps, and then some concerns means that there was no report about a random sequence generation or allocation concealment. Okay, so what we did is that we tried to assess for this domain and reporting the study is having low risk of bias, high risk of bias, or some concerns with respect to only this domain. Okay, so similarly we have to assess for each of these domains. For example, bias due to deviation from intended intervention means, for example, most of the RCTs will be registered in a standard registers or even standard registries, or even it can be published as an original article in a protocol format itself. Okay, so what we have to do is that we have to check the protocol and see whether they have followed the same intervention that they have intended in the protocol. Okay, for example, they wanted to give this drug at this much dosage at this much interval. Okay, for example, in the protocol they have mentioned like that, but in the original article that is published, they have given a higher dosage or lower dosage, or they have increased the frequency of giving that particular intervention. Or for example, in the protocol, they have mentioned that they are going to give that intervention for only 6 months, but in the original article, they have mentioned that they have given it for 9 months. Okay, so these are some of the deviations from the whatever their intended intervention is. Okay, so like that, so you have to see that, compare with the protocol and see whether they have deviated from the initial protocol. So here also, if there is no deviation, means you will report it as having low risk of bias. So if there is a deviation present, means then you have to report as high risk of bias. If you cannot find a protocol, or if you cannot find out how whether it was deviated or not itself, means you have to report it as some concerns. Okay, similarly, bias due to missing outcome data means first you will see whether there was any missing outcome data was there in that particular trial. And if there is a missing outcome data, means whether it was properly analyzed. For example, whether they have done a intention to treat analysis or per protocol analysis. Okay, so like that, whether they made any analysis technique to handle this missing outcome data or not, you have to check. Okay, so similarly, bias in measurement of outcome is nothing but where they use a standard tool, a standard measurement method for assessing a outcome. Okay, and finally, it is the bias in selection of reported results. Okay, for example, in the protocol, they would have mentioned that they were going to report some 5 to 6 outcomes, but in the final original article, they would have reported only 2 outcomes. They finally assess the 2 outcomes and reporting only the 2 outcomes. Okay, so they have selectively reported some results which they are able to obtain. So the 3 outcomes which they have reported in the protocol has not been reported. Okay, so like that, there might be some bias due to the selective reporting of the results also. Okay, so like this, for each of these domains, what you will assess is that you will check the full text of the article. You will mostly go through the methodology and results section and see whether there is any deviation from the standard protocol. Okay, so for each of these domains, you will give it as having low risk, high risk, or some concerns. Okay, so for example, now we have graded each of these 5 domains. Okay, 5 domains, each of the domains you have graded as low risk, high risk, or some concerns. Okay, so how you will finally establish that particular study is having high risk, low risk, or some concerns. Okay, so there is a standard criteria that is also available for this. For example, first, how you will establish that particular study is having low risk of bias is that study should have reported low risk of bias in all the 5 domains. Okay, so all the 5 domains, if the answer is low risk of bias is for that particular study, means then you can grade that particular study is having only low risk of bias. Okay, so some concerns is even if one of the domain, okay, there are 5 domains are there, even if one of the domains you report it as some concerns. Okay, for example, you are not able to establish whether that particular process was done or not. You cannot establish whether there was a randomization process done or not. You cannot establish whether the selective reporting of results was done or not. Like that, even if you report for even one domain, then you will grade that entire study is having some concerns. Okay, and another thing is that none of the studies should be reported as high risk of bias. For example, one domain is reporting as some concerns, means all the other 4 domains should be reported as low risk of bias to be called that study as having some concerns. Next is high risk of bias. How will you grade high risk of bias is that even if one of the domain is having a high reporting as having high risk of bias, for example, randomization process, that the study has mentioned they have not done random sequence generation or allocation concealment, but they have followed all the other 4 domains properly. In spite of that, you will grade that particular study is having a high risk of bias. Okay, so either at least one of the domains should be reported as high risk of bias, or if more than one domain is reported as some concerns. Okay, for example, randomization process and selective reporting of results. Okay, those 2 domains have come as some concerns. Okay, all the other 3 domains have come as low risk of bias, but still you will consider that particular study is having a high risk of bias. Okay, you can understand because the 2 domains have reported as some concerns and 3 domains have reported as low risk only. Okay, but in spite of that, since more than one domain has reported as having some concerns, you will report that entire study is having high risk of bias. Okay, so this is how you grade a study based on whatever the answer you are retrieving from each of the domains. Okay, so if all the domains are reporting it as having low risk of bias, then you will grade that particular study is having only low risk of bias. Even if one domain is reporting as having some concern, then you are going to report that study as having some concerns. Okay, even if one domain is reporting as high risk or multiple domains are reporting as some concerns, means finally you will grade that particular study as having high risk of bias. Okay, so this I know that this is a stringent criteria, but this is how the Cochrane has asked to grade any RCTs for risk of bias when you are doing a systematic review. Okay, so this is an example I have told. So whatever the tools I have mentioned in the previous slides, all the tools follow the same criteria only. Okay, there will be some set of domains or set of questions. For example, there will be some 10 questions. For each of the questions, you have to find out whether the study is having low risk of bias, high risk of bias, some concerns or unclear risk of bias. Okay, so like that you have to grade for each of the questions, and then finally based on such a criteria, like whatever the criteria I mentioned here for Cochrane's risk of bias tool, there will be a standard criteria. You will use that and finally grade that particular study is having low risk, high risk, or some concerns or unclear risk of bias. Okay, so this is how you do a risk of bias assessment. So to summarize, the risk of bias assessment is done primarily to check the internal validity of a study, which is nothing but how methodologically rigor was that particular study was conducted. Okay, so there are tools are dependent on what kind of study designs you are going to include in your review, and based on that, all the tools will have standard domains or standard questions you will ask, and you will check the methods and results section primarily and see whether the particular process was done correctly or not. Okay, if it's done correctly, you will grade it as low risk. If it's not done, if they have mentioned that they have not done correctly, means you will grade it as high risk. If you are not able to see whether it was done or not, then you will grade it as some concerns or unclear risk of bias. So now we'll move on to the final part of this session, that is the reporting of results. Okay, so this is the most important thing, because whatever the hard work you would have done the systematic review for 1 year, 1.5 years, or even 2 years. Okay, so whatever you have done, the most important part is that how we are going to report the results. Okay, so this only tells how much of a hard work you have taken in doing this systematic review and how systematically you have done that particular review. Okay, so for the reporting of results, there are 4 essential components. Okay, any systematic review you do, these are the 4 components that should be there in the final results you are reporting. Okay, so we'll see this one by one. First is a Prisma flowchart, which is nothing but whatever Dr. Gilbert has told in the previous session. That is the study selection process. Okay, there will be a flowchart which you need to tell that how many records you obtained from the initial database searching, and then how many you have included in the primary screening of title and abstract, and then how many in the secondary screening of full text, and then finally how many you are able to include in the review. Okay, you have to tell the numbers in a form of a flowchart. I will be showing the flowchart in the subsequent slides. Next is the characteristics of the included study. So this is nothing but whatever was told in the data extraction part. Okay, but what is the difference is that in the data extraction you will be comprehensively getting so many details about the particular study. Okay, but you may not be able to fit everything in a form of a tabular format. Okay, because this characteristics of included study should be reported in a tabular format in a standard thing. Okay, so in this tabular format you need not mention every of the details. Okay, there may not be enough space to fit all this information in a tabular format. Okay, so you need to put only the relevant details in that particular characteristics of an included study. That also we'll see with some examples. Next is the risk of bias assessment. So in the previous thing I told that how we will do the risk of bias assessment, but here we will see that how we are going to report that final risk of bias assessment. You finally graded that particular study or particular domain as having low risk or high risk. How you will finally report it in a form that we will see in the subsequent slides. And the final part of a result is a narrative or statistical synthesis. This is nothing but whether you are going to do limit yourself only to a systematic review, or you are going to go on to do a meta-analysis. Okay, so meta-analysis is nothing but you are going to do a statistical analysis of a systematic review. Just how you will do a statistical analysis for your primary study. For example, you have a descriptive statistics, you will do a measures of central tendency, range, standard deviation, all those things, and inferential statistics like p-value, the chi-square test, all those things you do for a primary study. Like that, if you do a statistical analysis for a systematic review, then that is called a meta-analysis. Okay, so if you are not going to do a meta-analysis, only stick with the systematic review means, then that is called this narrative synthesis. Okay, so we'll see why this narrative synthesis is required and how it needs to be done also. Okay, so first we will see about a Prisma flowchart. Okay, so this is the latest Prisma flowchart that is available. This is the Prisma 2020 flow diagram, which is only released recently. So there's an updated one. So here we will see for each of the boxes how we will fill and what are the information that needs to be filled. Okay, so first we will take this identification of studies via databases and registers. Okay, so here the first box, what it tells is that what are the records identified from databases and registers. Okay, So there are, as told by Dr. Gilbert in the previous session, you can retrieve data from multiple databases. You can get from Medline, Embase, and so many databases are there. You can get records. Okay, so you can, for example, you get some 1,500 records from Pubmed, and some 800 records from Embase, and some 400 from Scopus. Okay, so you get this multiple records. For example, finally you are able to get some 3,500 or 3,600 records. You are able to get from multiple databases. So that is the number you need to fill in this particular box. Okay, in the databases you have to mention that n equal to 3,600 or 3,500, how many ever results you are getting as a combination from multiple databases. Okay, you can either mention it like that in 3,500, or also you can mention the list of the databases. For example, you can mention Medline 1,500, Embase 800, Scopus 400, like that. You can either mention the database name and tell how many results you obtained from each of the database, or you can give a comprehensive number that out of all the databases, I got the databases n equal to 3,500. As a whole, I got 3,500 results by executing my search strategy. Okay, so these registers are nothing but there are also standard registries that are available. For example, there is a CTR register in India. There is a clinicaltrials.gov, that is a US based registry. There is even a WHO register platform for randomized control trials. Okay, so you can even search those registries and find out how many ever relevant trials that you can include for your particular review. Okay, so in addition to the databases, you can also search the registries, like whatever I told, the WHO registries or clinicaltrials.gov, like that. There are standard registries. You can even conduct search in those registries and report how many you are able to include here. Okay, for example, in registries you can put n equal to 200 or 300, how many ever results you are retrieving for your particular review. Okay, that is what you need to fill in your first box. Okay, here the next box is that how many records were removed before screening. Okay, this is nothing but what Dr. Gilbert told, that is how that you tend to get duplicates when you going to search multiple databases. Okay, for example, you go in Medline, you got 1,500, and Embase you got 800. But for example, there might be some 500 records that might be duplicate in both, that might be you could have retrieved in both Medline and Embase. Okay, so those are duplicates. Okay, so those duplicates you need to identify and remove before you do the title and abstract screening. Okay, so that number you need to report here. For example, you finally retrieve some 3,500 records in your databases. Out of that, maybe some 1,500 or even 1,000 or even 500 may be duplicates. So that number you need to mention it here. Okay, how many records you have removed before screening because they were duplicate records. Okay, that you need to fill in this particular box. Okay, so next is that how many records were screened. Okay, so finally, so you got the 3,500 records in your initial database search, and then you removed some 500 duplicates. Okay, so finally, how many records you're going to screen for title and abstract were 3,000. Okay, so the 3,000 you need to put it in this box. Okay, so that is the number. So then what this box means is that how many records were excluded. Okay, so now we are doing a primary screening, that is a screening of title and abstract. Okay, while screening the title and abstract for those 3,000 records, you are excluding around some 2,700 or even 2,800 records. Okay, because all those 2,800 records are not relevant to your particular review, you can identify from your title and abstract screening itself. Okay, so the number you need to fill is that, for example, I am excluding 2,800 records because of the title and abstract screening, because they are not relevant to my particular review. Okay, so if you remove the 2,800 records from the 3,000, then finally you will seek retrieval of some 200 full text. Okay, so finally you narrow down your 3,000 to 200 records. Okay, so what this box means is that how many reports you are going to seek for retrieval. Why this box is important is that even though you narrow down to 200 articles, you may not be able to get full text for all the 200 articles. Okay, even some journals you may not have access even through your institution also. Okay, so that's why this box is important. Like finally you want to retrieve 200 full text, but how many you are not able to retrieve full text. Okay, for example, you got you need to retrieve full text for 200, but you are not able to retrieve for only 190 articles. For 10 articles, you are not able to retrieve the full text even after contacting the primary author, even after obtaining the primary author, like that. Okay, so you need to mention that 200 articles were sought for retrieval, but out of that I am not able to retrieve 10 articles even after, like, I don't have access to that, or I'm not able to get that even after contacting the primary author. Okay, so finally you are assessing the eligibility for 190 articles, full text articles, which you are able to retrieve. Okay, so that number should be filled in this box. Okay, next is that out of those 190 full text you have gone through, how many are going to exclude. Okay, for example, you have gone through 190 full text against the eligibility criteria you had, and then you are excluding 180 articles. Okay, so that number should be put here. Okay, for example, I have screened assessed for eligibility 190 records. Out of that 190 records, I am excluding 180 reports. Okay, and along with 180 reports you are excluding, you are going to tell reason why you have excluded those 180 articles. Okay, it doesn't necessarily mean that you have to put 180 numbers and report why you excluded that particular data. It is nothing like that. You can always club the reasons in a separate format. For example, it may be having different participants or different outcome, or whatever the information you need to do analysis, it's not mentioned here. Okay, there might be some common reasons. You can club it together and report it here as reason 1, 2, and 3. For example, here you can report as different outcome, 50 studies, different participants, 45 studies, and different like information that is necessary for analysis is not reported, 20 studies. Like that, you can club the reasons together and report it in a form of 3 to 4 reasons here. Okay, so that is the number you need to report here. Out of the 190 I have retrieved for full text, I have excluded 180 studies because of these reasons. Okay, so finally this number is that nothing but how many studies you are finally including in your review. Okay, that is finally comes to 10 studies. Okay, so these are the 10 studies I am going to include in the review. Okay, so this is how you fill a Prisma flowchart for identification of studies via database and registers. For example, if you are going to include the gray literature also, that is unpublished literature that is present like form of a dissertation or like in the form of any government documents, policy documents, or available in any websites as unpeer reviewed articles or preprints, like that, if you are going to include means that needs to be filled in this particular box. Okay, that is the records identified from like websites, organizations, or citation searching. Citation searching is nothing but you are going to go through the references of whatever the full text you have retrieved. Okay, because sometimes you can find some studies which you are not able to retrieve even from the database also. Okay, like that, from the references also you can get some relevant studies. Okay, so if you are going to do identification through the multiple methods also means, then you have to fill this box. Okay, it doesn't comes under the database or AST searching. This is a separate search you are doing in the form of a gray literature search in your library, in your organization, in some websites, or going through the reference of the whatever the full text you have retrieved. Okay, so out of that, how many you sought for retrieval, and how many you could not able to get the full text, and how many you finally able to assess for eligibility, and how many excluded, and how many were included. Okay, for example, for out of this, maybe you would have included some 2 studies. Okay, so that you need to add and finally report it as 12 studies. Okay, for example, 10 studies you have included from this database searching and following this process, and 2 studies you might have got from through other sources, gray literature or citation searching from this also. Okay, so finally in this box you need to fill it as 12 studies, including both database and registers as well as other methods which you have employed. Okay, so this is for a new systematic review. If you are doing a new systematic review, this is the flow chart in which you need to report it. Okay, so this is a flow chart which you need to use if you are doing an updated systematic review. Okay, for example, you have done a systematic review in 2020, then again you are going to do a updated systematic review in 2025. Okay, so in this and that point, then you need to fill this chart for as a Prisma flow chart for your study. Okay, nothing but this is almost the same flow chart. There is one extra addition is there, that is how many studies were included in the previous version of your review. Okay, so that is the next. For example, there was in your previous review you would included some 12 studies, and this new updated search you got some 10 more studies. Okay, then finally you need to put here it as 22 studies. Okay, so here the only one extra box is there, which is nothing but how many studies you included in your previous systematic review. Okay, then how many you are finally including in the new studies in your review. Okay, that you will total and finally tell it as 20 studies or 25 studies. Okay, so this is the only minor difference between the Prisma flowchart for a new systematic review and a Prisma flowchart for an updated systematic review. So this is an essential component of any systematic review you are doing. So this should be reported as a first figure. Like for example, this should be in this flowchart format. It should be reported in all the systematic review which you are doing. So this is the first component of your results. Next is the characteristics of the included study. Okay, so this consists of so these are some of the important information that needs to be reported in your characteristics of included study. As I already told, it should be reported in a tabular format. Okay, so for example, so as I already told, you need not put everything you have extracted as a data into a tabular format. You need to include only the relevant details or the important details you need for that particular study. You can report it in the tabular format. Okay, so the first thing is the general information, that is nothing but the author last name and the year of publication. Okay, for identification of that particular article. Next is the method section. Method section you can mention a study design, study duration, sample size, sampling technique, whichever you think is relevant for that particular systematic review. Okay, for example, if you are doing only systematic review of randomized control trial, then it doesn't make sense to include a separate column as study design. Because whatever the 10 studies you included, everything you're going to report as RCT, RCT, RCT. Okay, so it doesn't make sense to include study design as a separate variable if you are going to do a systematic review of randomized control trials. Maybe if you want to include as whether it was a cluster randomized or parallel randomized, or if you want to tell whether it was a multi-centric study or single-center study, like that, if you think it is important to mention that extra characteristics of an RCT, then you can include as a separate column. Okay, so like that, whichever you think is important only, you need to include in the tabular column. Okay, so these are not per se the format. These are some of the important information that you might require in your filling the table. Okay, next, as I told, in the participants, you can mention the study setting and then relevant details on the health status. For example, the comorbid status. Maybe you want to tell that this study participants were conducted among DM patients. This study participants are conducted among hypertension patients. Like that, if you want to tell that and you think it is relevant for your review means, then you can mention it as a separate column. Okay, then if it's for an intervention means, then you can mention the important details related to the intervention, like what is the dose of that medication, or what is the frequency in which it was given, or what is the mode of administration, whether it's a oral intervention or intravenous intervention, what is the duration in which it was given. Like that, if it's a systematic review of interventional studies, then you need to mention about the intervention related details also. Okay, next is the outcomes. That is the what are the clear list of outcomes. For example, if your systematic review has multiple outcomes, some 4 to 5 outcomes means not all the studies will report all the 5 outcomes. There may be some studies may be reporting only 2 outcomes. One study will be reporting only one of the outcome which you are seeing. Okay, so for each of that study, you have to report that what is the outcome can be seen from that particular study. Okay, for example, if you have only one outcome in your systematic review means, then it doesn't make sense to include it as a separate column, because you are going to put the same outcome name in the all the rows. Okay, so that's why you have to see whichever is important for your review, and that only should go in your tabular format. So this also you can, there is a difference in terms of reporting depending on the whatever the study design. Okay, similarly, how you did a risk of bias assessment based on the study design you are including, the table for the characteristics of included studies also you can report based on what study design you are reporting. Okay, for example, if you're including intervention studies like RCTs or non-randomized trial, then you need to report on these details. What is the frequency of intervention, duration of intervention, nature of duration intervention, and what is the analysis. Like this, these are the important information with respect to intervention that you need to report for an RCT or non-randomized trial. For example, if you are including only observation study, for example, for risk factor identification or etiology identification, then you need to include details about the exposed and non-exposed, their study characteristics. Okay, whether they have any comorbidities, like that, you need to mention the exposed and non-exposed group related characteristics. If it is about a cross-section study or a prevalence study, then the main thing is that what is the sample size, what is the sampling technique they used, what is the participant characteristics, what is the outcome measurement tool, because you are going to tell the prevalence of that particular outcome. You need to know what is the outcome measurement tool that was used, whether it was validated or not. Okay, so that's why depending on the study design also, whatever the things you are going to report in the table differs. So this is a model table. So this was actually a systematic review of randomized control trials. So that's why they have this is a model table why they have the general information about the author details and the year and which country it was conducted, and then about the participant characteristics. They have given like how many person were in the intervention group, that is yoga group, and how many in the control group. What is the mean age of the participants? What are the gender distribution? That is how many females were there, and then about the intervention related details, because since it's a systematic review of interventional trial, so they have given the intervention related detail also. What type of yoga was given, how many minutes it was given, and how often it was given. Okay, so they given that information also, and also the outcome measures. Since they have some multiple outcome measures, see they are given like for example, this study has reported only on pain outcome. This study has reported on 2 outcomes. Like that, they have given information about what kind of outcome was reported by each of these studies. Okay, so it's not like, for example, if your systematic review has 5 outcomes, it's not necessary that all the 5 outcomes need to be in a study to be included. Okay, even if one of the outcome whichever you are seeing is there, you can include that particular study. Okay, so that is what needs to be filled in for example, a systematic review of interventional trials. Okay, for example, this is a systematic review of a prevalence study. Okay, so here the authors have tried to see what is the prevalence of metabolic syndrome in India. Okay, so here they given the information that is relevant to that particular setting. Okay, for example, which state it was conducted, what is the geographical region, what is the setting, whether it was conducted in urban area, rural area, because there may be difference in the prevalence based on the type of setting or type of region, and what age group it was conducted. What about whether it was conducted only among males or among males and females? What is the sample size? And finally, what is the outcome measurement criteria? That is, what is the diagnostic criteria they use for measuring the metabolic syndrome? Okay, so for so you can see there is a wide difference between the table reporting in the both a systematic review of randomized control trials and systematic review of prevalence studies. Okay, so there you saw entirely about the intervention related details, participant related details. But here you are seeing the mostly about the study setting, sample size, and what is the outcome measurement tool. Okay, so that is what you need to understand. Whatever the type of review you are doing, you need to identify whichever is the relevant variable and only include that in the characteristics of an included studies table. Next is about the risk of bias assessment. Okay, so I showed you like how you are going to finally establish whether that particular domain or study has a risk of bias. Now the reporting can be in the form of either in the form of figures which can be generated from a standard software. Like for example, Reumann software can generate you this particular figure. Okay, so nothing but each of the study, whether it was having low risk of bias, high risk of bias, or some concerns with respect to each of the domains. For example, random sequence generation. If there is a green symbol, means there is a low risk of bias. For example, if there is a red symbol indicates there is high risk of bias because the blinding of a participants was not conducted. The question mark means they are not clear whether it was bias is present or not. They are not clear, so they have mentioned this question mark. Okay, so this is one form of reporting the risk of bias assessment. Okay, so there is another format which is also easier format, that is a tabular format. Okay, so there is no hard and fast rule whether you should report in a form of figure or table. You can use either of the form, whichever you are comfortable with or whichever you are feasible to do, you can report it. Okay, so in table also nothing you're going to just to do in each of the study whether they had high risk of bias, low risk of bias, or here since this table is based on a previous risk of bias tool, they have mentioned as unclear. Okay, as I already told, the risk of bias 2 tool was only launched recently, so this was a table based on the previous risk of bias 2 tool. Okay, so here they have mentioned as unclear instead of some concerns. Okay, so that's why for each of the domain you need to report whether it is having high risk of bias, low risk of bias, or some concerns. And finally, overall risk of bias, whether it was high, low, or some concerns were present or not. Okay, so this is an easier way of reporting also, where you can report in a form of table. You can also report in a form of figure if you are able to generate that particular pictorial format. Okay, so final part of a result is that is reporting of pooled results. Okay, so this is important because finally whatever the review you conducted, whatever the data you extracted and did, you're going to finally interpret those results. Okay, that interpretation of results can be done in two forms. Okay, that is if you are going to only stick with the systematic review, or you're going to go on to do a meta-analysis also. Okay, so as I already told, if you are going to only stick with systematic review, you're not going to do a statistical analysis of the review, then you can only do the narrative synthesis. You can just narrate the findings in a description format. Okay, so meta-analysis is if you are going to do only a statistical, if you are go on to do a statistical analysis of the review. Okay, so that is a quantitative pooling of data evidence. Okay, since our CME is focusing only on systematic review, I'm going to tell you how you are going to report the results. If you are going to do only narrative synthesis, that is only systematic review, if you are going to do means how you are going to report the results. So first we need to know is that why narrative synthesis is required. It's not like I don't know to do a meta-analysis, so that's why I'm sticking with systematic review. It's not like that. There are some scenarios in which you cannot do a meta-analysis, okay, or you should not do a meta-analysis. Okay, so it's not like you don't know to do a meta-analysis, that's why they are sticking with a systematic review. Okay, so it's some scenarios that it may not be possible to do a meta-analysis itself. That's why the authors would have stuck on to doing only a systematic review and just gave a narrative of whatever the findings they were able to synthesize. Okay, so the primary reason why we need a narrative synthesis is that methodological heterogeneity. Okay, so what this means is that whatever the studies that are conducted, for example, one study in India, one study in USA, like that, you are going to, anyways going to take studies from multiple settings. Okay, for example, even though if you take from multiple settings, if the methodology is almost similar between all the studies, means you can go on to do a meta-analysis. But you find that the methodology is very different. Okay, for example, the type of intervention given here is different. Whatever is given in USA is different. The dose is different, and the duration. For example, here we are giving for only 1 month. There they were given for only around 2 months, or even like for example 1 year or 2 years. Okay, so if you find some methodologically, if the studies are entirely different, means it doesn't make sense to pool all the data and give one final estimate. Okay, so that is the primary reason why we need a narrative synthesis. If you find the methodology is entirely different from whatever the studies you included, for example, you included 10 studies, and all the 10 studies they are methodologically very different. Okay, so you cannot, it doesn't make sense to pool those data and give one final estimate. Okay, so these are some of the reasons which I have listed out for why we need to do a narrative synthesis. First is a broader research question. In the first lecture itself, it was told that for a systematic review, you need a narrower research question. but it doesn't mean that you cannot do a systematic review for a broader research question. Okay, you can see there are some systematic review like asking like interventions in improving a mental health of a community. Okay, so that is a very broad research question. Like they have not mentioned what type of intervention or what type of mental health measure. It can be depression, stress, or anxiety, or intervention can be cognitive behavioral therapy or individual counseling. Like that, there are so many pharmacological interventions. Like that, there are so many interventions are there. There are so many outcomes are there. So whether you can give a one final pooled estimate for that particular research question, it's not possible, right? So for those kind of scenarios where you have a broader research question, you need to go on to only do a narrative synthesis. It's not possible, or it should not do a meta-analysis for such a broader research question. Okay, so ideally a systematic review should have a narrower research question. But if you have a broader research question which you want to do a systematic process and do a systematic review, means you can go on to do that, but you should stick on to only narrative synthesis and not try to do a statistical analysis and give a final one pooled estimate. Okay, so that is the first reason why you need to stick on to only narrative synthesis. Next reason is including wide range of research designs. Okay, for example, in eligibility criteria itself, for example, we will decide that we are going to include only RCTs. We are going to include only observational studies. But sometimes it may not be always feasible to do only one study design can be included in that particular setting. Okay, for example, you have some complex or some intervention like some surgical intervention which is not possible or feasible to do as a randomized control trial. Okay, for example, you want to do a systematic review comparing two surgical interventions and you are able to find only one or two randomized control trials, but you're able to find some 20 retrospective studies. Okay, because it was not ethically possible to do them it as a trial. They would have gone back and see that how many people have undergone this type of surgery. For example, 50 people has undergone this type of surgery, 50 people has undergone this type of surgery. What is the outcome? What is a good outcome or poor outcome in these two groups? Okay, they would have seen these two things and they have just compared and written that. Okay, that is just a retrospective study. They have just gone back and seen that from the records how many people have undergone this type of surgery, and finally reported the outcome. Okay, so for example, since it's not possible to include only RCTs in that particular research question, you are including retrospective studies, you are including longitudinal studies, observational studies, like that, non-randomized trials. Okay, for example, if you are including these kind of wide range of research designs in your systematic review, means then you should not do a meta-analysis, because it doesn't make sense if you are trying to pull an estimate from an RCT, non-randomized trial, and an observational study. Okay, so as much as possible we should stick on to only one research design while we are doing a systematic review. But if it's not possible to do a systematic review using one study design, then we can go on to include multiple study designs also, but we should not go on to do a meta-analysis as it won't make any sense. Okay, so like that, there are some other reasons also, like different set of intervention, like what I told, there might be some difference in the whatever the duration that was given, whatever the dose that was given. Like that, if there is a wide variation in the type of intervention that is given, means you should stick on to only narrative synthesis. And also different outcome measures, like what I told for intervention in improving the mental health. Okay, the mental health outcome can be a depression, anxiety, stress, psychological distress. There are so many outcomes are there. Okay, so like that, if you have a different outcome measures where it's not possible to pull it as a single estimate, means you stick on to only a narrative synthesis. The final reason is lack of statistical reporting, which is nothing but the study whatever you included. For example, you included 10 studies, but the outcome was not properly reported or reported in the way we want to analyze. Okay, for example, you want a mean of that particular outcome which you want. Okay, for example, systolic BP mean you want, but none of the studies have reported a mean of systolic BP, or only reported mean of like mean arterial pressure or something else. Okay, which you are not able to derive whatever the outcome you want to assess. Okay, so like that kind of lack of statistical reporting from the studies which you have retrieved, then you cannot do a meta-analysis. It's not possible for you to do a meta-analysis. Okay, so in these kind of scenarios, so these are some of the 5 reasons which I have reported. There may be some multiple reasons also, but these are the primary reasons why you should stick on to only narrative synthesis and not go for meta-analysis. Okay, so you can bring everything into one term, that is a methodological heterogeneity. Methodologically, the studies are entirely different, that you cannot do a meta-analysis. Okay, so now we will see how we are going to report a narrative synthesis. Okay, this also differs based on whatever the studies you are including in your review. Okay, for example, here I have reported for RCTs or non-randomized trials. Okay, for example, here I have given, like for example, all the 5 studies that assess the symptomatology yielded a significant reduction in a depressive symptom regardless of a study design and large effect sizes. So what it means, they have compared across multiple interventions. Okay, multiple interventions and multiple study designs were included. So regardless of study design means they have included studies from multiple study designs. They have included observation studies, longitudinal studies, retrospective studies. Like that, they have included multiple study designs. So they did not go to meta-analysis, okay, because it doesn't make sense to pull estimate from multiple study designs, okay. So that's why they stuck on to a narrative synthesis. What they have mentioned is that, for example, they have assessed a particular intervention, and that particular intervention was reported by 5 studies, okay, and all those 5 studies have reported a significant reduction in the for this particular outcome, that is a depressive symptoms, and regardless of the study design. They are telling that in spite of whether it's a retrospective study or prospective study, they have reported a significant reduction in the depressive symptom with large effect sizes. This what they mean is that maybe the odds ratio, risk ratio might be like very much higher, okay. For example, the protection might be 70% less or 80% less, like that. That might be a significant reduction in the larger amount, okay. So that's what they mean by this narratively synthesizing the findings, okay. This is nothing but what you do in a review of literature. Like most of us would have done a review of literature for a thesis or protocol writing, okay. In review of literature, what we will do, we will just try to summarize a finding of a single study, okay. In a separate paragraph, we will try to summarize a finding of a single study. Here in narrative synthesis, what we do is that we are trying to summarize findings from multiple studies in a single paragraph, in a single sentence, okay. For example, here they have summarized the findings from 5 studies, okay. All the 5 studies that assessed are able to find a significant reduction irrespective of the study design with larger effect sizes. Similarly, in the next statement, you can see that they have assessed a different intervention, and for that intervention, 5 out of 6 studies. For example, they have also mentioned what type of studies, like 3 out of 3 were pre-post studies, and 2 out of 3 control studies observed a significant improvement in the mental health symptoms, okay. So like that, you can report for an RCT or a non-randomized trial which you are trying to assess the effect of an intervention, then you need to summarize like this, okay. This is how you summarize in a single sentence how they have found out whether there was any significant reduction was there, how many studies have reported that, and what is the magnitude of association, and what is the study design in which they are reporting a positive or negative association, okay. So next is for an observational study, that is, for example, etiology identification or risk factor identification. Here there is an example, okay. For example, 5 out of 7 studies found a significant association between obesity and type 2 DM, okay. And also they are also go on to tell that there was with a higher magnitude of association found in the longitudinal studies and Western countries, okay. So they are telling that they have included some 7 studies which are assessing the association between obesity and type 2 DM, and they have included multiple study designs, okay. So that you can find out by telling that they have found specifically among the longitudinal studies, though they included prospective studies as well as retrospective studies, okay. So that's why they did not go on to make a meta-analysis, okay. So what they have done is that out of the 7 studies they have included, 5 studies have reported a significant association, that is obesity as a risk factor for a type 2 DM, okay. And also they went on to report that they are finding higher magnitude of association in the longitudinal studies, that is the forward-looking studies were showing higher magnitude of association. Like for example, you combine, like for example, the retrospective studies might be reporting a risk ratio of 1.5, okay. They are telling like longitudinal studies might have reported like 3.5 or even 4 as a risk ratio, okay. So that's what they mean by higher magnitude of association. And also among Western countries would have reported a higher risk ratio when compared to the low and middle income countries or other countries, okay. So that's how they summarized for a observational study for etiology identification. Next, for a prevalence study, okay. So for prevalence study, it's straightforward. Like for example, any introduction you write that the prevalence of this disorder range from this range to this range with high burden was found in this particular region, okay. This is what is done as in this example also. That is prevalence of internet gaming disorder among the school going adolescents ranges from 5% to 25%. With highest burden was reported in the South Indian states, okay. So now you might have a question like, since it's only a prevalence study, they can go on to do a statistical analysis, right? They can go on to do a meta-analysis and report one final pooled prevalence as some 10% or 50% rate. There might be some scenarios where you may not be able to do, even though it is a systematic review of cross-sectional studies, okay. So what might have happened here is that, for example, internet gaming disorder, for example, they have included 10 studies, okay. Out of those 10 studies, 8 studies, the authors would have developed their own tool and they would not have validated it or standardized it, okay. They might have some different scoring system. They have developed some 10 questions. They have given some 10 scores, and they have reported as having this much prevalence of internet gaming disorder. Okay, so since out of 8 out of those 10 studies doesn't have a validated or standard scale which have assessed that particular outcome, it doesn't make sense to pool everything and report one pooled prevalence as internet gaming disorder. Okay, so that's why it's not that in, for example, it's a prevalence study, you can finally go on to do a meta-analysis. Okay, there might be some scenarios where you should not do a meta-analysis, even though it is a systematic review of cross-sectional studies. Okay, you need to, that's why you need to check the outcome measurement tool, whether it was a validated tool or not. Okay, that is also one of the reasons why you should not go on to do a meta-analysis and stick on to only a narrative synthesis. So that is all how you report a narrative synthesis. So to summarize, so first, risk of bias assessment is nothing but you check the internal validity of a study, that is a methodological rigor, and you can do based on the study designs, the tools varies. And what you do is that for each of the domain you or each of the question you report as low risk, high risk, or uncertain risk of bias. And then finally, based on each of the domain answers what you got, you finally grade that particular study is having low risk or high risk of bias. And then you finally report it in a form of figure or in a tabular format also. Okay, and the results component should be, there are 4 essential components are there for any systematic review. First is a Prisma flow chart, which is there a separate format for new systematic review and updated systematic review. And then characteristics of a study should be reported in a form of a table. And then the risk of bias assessment, as I already told, can be in a figure format or in a tabular format. And then finally is the reporting of pooled results, which can be in a form of a narrative synthesis if you are going to do only systematic review, and in a form of meta-analysis if you are going to do a statistical analysis of whatever the review you did. Okay, thank you.
Thank you so much, sir, for your very informative and exuberant session. So, sir, let's quickly move on to the critical appraisal, and let's do it for like half an hour or so, and then we can break. Is it okay, sir?
Wait, I will see.
Meanwhile, your questions, yes, it's been clarified by Dr. Gilbert, sir, in the chat box. And if you have any more questions, you can put it up here. After this critical appraisal session, we'll have an open house session for discussion.
Hello. சொல்லுங்க சார். அதான் ஸ்லைடு போடுறேன் சார். இப்போ அப்படியே 2 பேரும் அப்படியே மைக்ல ஆன் பண்ணி டிஸ்கஸ் பண்ணுவோம்.
So the next session will be with critical appraisal of a systematic review article, and followed by it, we'll have an open house session. Over to you, sir.
Thank you, Dr. Sharath. So this session will be like a rapid session. Like what we are planned to do for a critical appraisal is that we are just going to show some of the examples with how a eligibility criteria was reported in some of the studies which were poorly framed studies, and how it should be ideally reported. Like we have some examples, and we are going to tell like how it was reported and how it should be reported. So we'll quickly move on to that. So first is, these are some of the checklists that are available for critical appraisal. Okay, so this also depends on what kind of study design which you are going to include in your particular systematic review. Okay, so this is a standard checklist which has been used. That is a Prisma checklist which you can use if you are going to do a systematic review of some randomized studies or any interventional studies. If you are going to do a systematic review means then you can use this Prisma checklist. Okay, this is also a latest checklist. There is a Prisma 2020 checklist. Like before that, the people used to use the Prisma 2009 checklist. So it has been updated almost after a decade. So this is a new checklist which everyone should follow. That is a Prisma 2020 checklist. Okay, so this checklist can be used if you are doing a systematic review of interventional studies or a randomized control trial. So next is the MOOS checklist, which is nothing but meta-analysis of observational studies in epidemiology. Okay, so if you are going to include observations, you are going to do a systematic review or meta-analysis of a observational study, you have to use this checklist. Okay, similarly there are checklist for if you are going to do only a systematic review of diagnostic accuracy studies. For example, you want to find what is a pooled sensitivity and specificity of a tool. Okay, for example, you want to do a what is the pooled sensitivity and specificity of like rapid antigen test for COVID-19. Okay, you are pulling an estimate from multiple studies and giving one final estimate means for those checklists, there is a separate Prisma checklist available is there. There is Prisma diagnostic test accuracy checklist. Okay, so there are other Prisma extension also is there. For example, if you are going to do another qualitative evidence synthesis like that, if you are doing depending on whatever the study design which you are going to include, the checklist varies. Okay, so these are the commonly used checklists because these are the common type of study designs which we use, that is diagnostic accuracies or observational studies or interventional studies. So this is an example I am showing. Like for example, we saw that the eligibility criteria, what are the things that needs to be reported. Okay, but here you can see that the person has reported that inclusion criteria required that studies outcomes on health effect related to pesticide exposure and citation regarding the pesticide exposure and cardiovascular disease. What they want to assess that effect of pesticide exposure and cardiovascular disease. Okay, but this is how the inclusion criteria was framed. Okay, none of the format which we have told, like participants, like whatever the exposed group, non-exposed group, all those things, it is not being followed in this particular eligibility criteria. Okay, so we are going to report a study which has properly reported this eligibility criteria. Okay, for example, this study has classified based on what is the type of studies. Okay, for example, they have told that they have included only parallel arm, individual or cluster randomized RCTs, and the crossover studies were excluded, and they have also given reasons why they have excluded the crossover studies, and they have also reported that they are going to include only the full text articles, and also they are not going to include any conference abstracts or any unpublished data. That is, they are not going to include any gray literature. Okay, similarly, they have also mentioned, like the same study, they have mentioned what type of participants they are going to include. Okay, so they have included studies that are conducted only among the adults who are aged more than 18 years who already have a type 2 DM or hypertension. For example, this study was conducted to find what is the effectiveness of peer-led intervention on diabetes and hypertension patients. So for them, the correct participants were adults who are aged more than 18 years who are already having a diabetes or hypertension. Okay, like that, this is a type of intervention what they have reported. Okay, so as I told, they want a peer-led intervention, so they have included studies that assess the effectiveness of intervention that is provided by the peers of diabetes or hypertension patients, and they also went on to define what is a peers. Okay, they have defined the peers as the people who are not trained medical professionals but similar to the target population, like in the terms of, for example, if they are teaching for a diabetes patient, they should have been a diabetes patients for giving some teaching to the patients. Okay, like that, they have given some definition also for whatever the intervention they are including. Okay, like that, they have all, then finally they went on to tell what kind of outcome measure they are going to include. Okay, like that, what is the reduction in the HbA1c level if for the studies among a type 2 DM, and for reduction in the systolic blood pressure for among the hypertension patients. Okay, so this is how you report a eligibility criteria. You should stratify it and report it in your method section as what type of participants you're including, what type of intervention you're including. You should give a definition for your intervention. Okay, for example, if you are including a intervention as a drug, means you should tell exactly what dose or in what range of dose you're going to include, up to what duration on that intervention should be given. Like that, you should give a clear description of whatever the components that is there. Similarly, this is a search study that has been reported in one of the article. This article want to find out what is the risk factor for hypertension in like young adult population in India. Okay, so this was the keywords that this is the entire search strategy that has been reported in that particular study. Okay, so here they have reported that only those keywords, like for example, they have only some few keywords only. It's not like comprehensive words they have used. Like they didn't even comprehensively go on to check what are the other terms that can be used for hypertension or for risk factors or whatever. They could have tried to assess for some give a name of some of the risk factors at least. Okay, that also cannot be that also was not done in this particular search strategy. Okay, so a search strategy, as ideally as Dr. Gilbert has told in his session, it should have like whatever the possible terms that is possible for a participants, whatever the possible terms for exposure or non-exposure or intervention that should be given, and then what are the possible terms that can be used for an outcome. Like that, you should report everything with the Boolean operators with the standard search strategy which they have used for executing a search in a search engine. Okay, ideally we should report a search strategy for each of the search engines. Okay, for example, if you are doing search in Pubmed, means we have to report what are the search strategy we use for Pubmed. If you are going to do a search in Embase, means we have to report what is the search strategy we have used in the Embase. Like that, if you are doing a search in 4 databases, means we have to report what is the search strategy that we followed in all the 4 databases. So study selection and data extraction. Okay, so here this is a screening process in which a study has reported. Like for example, what they have done, they have reported here. Okay, so they have just given like first step they have did the abstract and title screening. Second step they did like full text screening. Like that, they have given an information. But what they missed out is that they did not mention like who did this thing, like who did this for primary screening process. It is also necessary to tell which authors did the primary screening process, and how many authors did this process, how many authors did the full text grading, whether it was finally justified by a third person to arrive at a consensus that which type of studies should be included finally. Those kind of information were missing in this screening strategy. Like here you can clearly see how to report that. Okay, for example, they have mentioned that search results were first imported into a citation manager, and then 3 authors independently screened for title and abstract against a predefined eligibility criteria, and then full text articles were again performed by 2 authors, and then electronic data was piloted, and then electronic data form was piloted. Like that, they have given information about each step, who did that, what they did, and against what criteria they did, entirely they have given. Okay, even this article went on to give a supplementary file to tell what was the process, that in a detail, like in a 2 to 3 page format, they have given the entire study selection and data extraction process. So this is a Prisma flowchart in which you can see that how many records were retrieved. Like this was an old format they have used. So this you can see that they have given like how many records were identified, how many records were duplicates were removed, how many were screened. Okay, but here what they didn't give is that what are the proper reasons why they excluded the 30 studies. Okay, they have given only poor quality as a reason, but it may not be always possible that poor quality was the only reason why it was excluded. Okay, ideally how it should be reported is that you should report, like for example, as I already told, you can even report for individual databases how many results were obtained, and then even if you can include the reasons, you can include reasons here also. Okay, for example, you are excluding 1083 reports in the primary screening itself, means you can report this primary screening process reasons also here in this particular box. Okay, so this is how you summarize. Okay, it's not like 1083 rows will be made. Okay, you can club everything into, for example, not in the CF public, whatever the population they want to do, it was not done in that particular population. Okay, they given 392 studies because of that. Like that, you have to summarize in a particular reason and then report it as finally. Okay. So next is the risk of bias assessment. This is how one of the study has reported how they have conducted this risk of bias assessment. They have finally converted the risk of bias into a quality, and just reported like this study is having high quality, this study is having medium quality. Okay, as I already told, risk of bias assessment should not be reported like this. Okay, it should ideally be reported like in a figure format like this, or in a tabular format like this, where you need to tell for each of the authors what are the domains assessed, and for each of the domains what is the risk of bias, and finally overall what is the risk of bias. Okay, so that is how need to be reported. So this is just a short session, like which we did because we could not accommodate every parameters that is mentioned in the Prisma checklist in this particular session. Thank you.
Thank you, sir. Dear delegates, the feedback form is being put on the chat box, and now the session is open for queries. You can unmute yourselves now and post your questions if you have any. Dear delegates, the house is now open for queries. If you have any queries, you can post here. Sir, one of the participants have asked to share a link for model comprehensive search strategy.
Yes, we will send the materials. We will send how a model comprehensive search strategy will be framed. Like for each of the databases, how it needs to be reported, we will send them.
Yeah. And sir, there was 2 questions which was asked during Kalaivani ma'am's presentation. And since ma'am is not there, I kindly request any of the speakers to take it up. One of the participants have asked, any data on number of systematic review in public health is available? Any data on systematic review in public health?
Like we don't exactly have the per se the statistics of how many have been conducted. Like maybe you can go on to that Prospero database and find out. Like they would have split among like each of the domains, like for example public health, obstetrics and gynecology, like that. They have a separate domains and they have reported how many systematic reviews have been registered till now in those particular domains. So you can go to the Prospero website and you can search for each of the like whichever whatever your subject of interest, you can search for those domains.
Okay, sir. And the other question was about scoping review. I guess it is addressed. Any other queries or yeah, any other queries? You can feel free to even tell your feedback, oral feedback if you want. You can unmute yourselves and can speak to the speakers.
Sir, I am Dr. Emmanuel Joshua from Banaras University.
Yes, Dr. Emmanuel. Yeah, you're
Sir,
audible.
actually, sir, it was a very excellent session because I have earlierly attended a session on systematic review and meta-analysis, but I just learned the steps how to do it. But when I practically went on to search for Prospero, I found very difficult, and I don't know what is Rayon software, how to do it. But the session gave a really, I mean, the speakers are very excellent in demonstrating how to use this Rayon software. So it gave me a hope actually. So when I started my systematic review, it's in hold almost for 5 months. I don't know how to proceed. I don't know where to get the help from. But now I'm getting a basic idea how to do it. So I am very glad that I attended this session. Sir, I wish that you please share the recording because it was very fast. It was very excellent, but it was very fast to process. I mean, my thought process was slow. So I wish that the recording is shared and the materials are shared too, so that I can, I mean, deal with my systematic review. Thank you, sir.
Yes, Dr.
Thanks a lot.
Joshua. Thank you. Thank you so much for your feedback. And we'll definitely share the link of this recording through YouTube, so you can access to it anytime you want.
Thank you, sir. Sir, and also, sir, and I wish this a brochure reaches in multiple public health groups because many of them are in need to learn this systematic review. But I don't think it has reached many of the participants. So next time, I wish it reaches a lot of participants so that there are more beneficiaries from your lectures.
Sure,
Thank you, sir.
sure. We'll definitely make it up big next time. Thank you so much for your kind words. Any other queries or any feedbacks you wanted to post up? Okay. So here we are. Since the feedback form is already there in the chat box, you can fill it up to get your e-participation certificate. The Department of Community Medicine sincerely thank our respected Chairman, Sir, Dr. Jagat Rakshagan, and President, Dr. Sandeep Anand, Sir, for giving us this space and resources for conducting such program. And we thank our beloved Dean, Sir, Dr. Edugundalu, Sir, for always pushing us out of our boundaries and for being a constant support system for us. And sincere thanks to dear Vice Principal, Dr. Mohana Sundaram, Sir, for always encouraging us. A heartfelt thanks to all the speakers who accepted our invitation and who prepared so much and gave us an exuberant, very crystal clear, precise presentation on systematic review. I guess the feedbacks are shown. Thank you so much for all the speakers. Sincere thanks to our CME observer from Tamil Nadu Medical Council, Dr. Vijay Raghavan, Sir, who has been present throughout this session. And our dear delegates, thank you so much for your wonderful time and participation. And we would like to extend our gratitude to the technical team for all the support they have provided, Mr. Stephen, Mr. Rosario, Mr. Balamurugan, Mr. Praveen and team. And last but not the least, thank you so much for our department people who have put in so much of effort to make this program a successful one. And I extend my humble thanks to our HOD, Dr. Kalaivani ma'am, and Dr. Vidya ma'am, Associate Professor, for giving me this opportunity. And the participation certificate will be automatically generated once you submit the feedback form. And we are planning to for next CME probably on meta-analysis. So we'll keep you posted on that. So looking forward to meet you all there. Till then, this is Dr. Sharath calling it a day. Thank you.